A very good evening. A very good evening to everybody, and welcome to World Thalassemia Day. I have the privilege of inaugurating this very special webinar this evening, and I've decided to do it differently to show that it's something that is truly close to my heart, and that thalassemia is something all of us need to be working on. To be thinking about and to be thinking differently about. And therefore, I welcome each one of you to this webinar tonight, which is being organized by the Society of Fetal Medicine Bengal Chapter on behalf of the Central Office of the Society of Fetal Medicine. And I congratulate the Bengal team led by Dr. Kanchan Mukherjee and, of course, our super leader, Dr. Kushagrati Ghosh, and for choosing this topic at the correct day, the correct time, because we do understand that on the 8th of May every year, we hold World Thalassemia Day. And the theme for this year, as you would have read in the newspapers and seen on the media, is to be aware, to share, and to care, and to work with the global community as one to improve thalassemia knowledge. But there is an element of sadness, because I'm really wondering whether this is a meaningless exercise. Because every time we open this page, as you see at the bottom of my slide here, you do see the 8th of May, and then you suddenly realize that, oh my God, has anything really happened? And we say, no, nothing has happened, because today, every 10th thalassemic in the world continues to be an Indian. Each year, 15,000 thalassemics are still born in our country. And about 42 million carry the beta thal gene in our part of the world. And nothing seems to have changed for the better in our national statistics over the past several decades. When we look at the Mediterranean, we look at Sardinia, we look at Cyprus, we say, how did they manage it? They have gone right ahead and brought down for the past 7 years their incidence of thalassemia. There are very few patients there who now need transfusion. There are very few patients there who need any drugs. And why have we not mentioned it? And on top of it, we've known since ever that our main problem is lack of awareness. And for those of us who do become aware, we forget very fast. We also know that consanguinity, which is such an important part of this whole exercise, is really something that you and me are aware of, but we don't seem to be doing much about. And I was shocked when I saw this that you see on my slide at the moment from Mordor Intelligence, which says that when we look at the thalassemia market, which means for desferoxamine, between 2020 and 2025, the fastest growing market, if you please, is Asia Pacific. A base year is 2021. And these 5 big pharma companies are going to be busy coping with patients. Well, of course, they're going to be busy because someone has not done their job the way it was supposed to be done. And there has been a failure of the medical profession, and there's been failure of government. But why has this happened? After all, we have a policy in place, and this was the prevention and control of hemoglobinopathies in India policy that was brought out by the Ministry of Health and Family Welfare, Government of India in 2016. It included thalassemias for sure. It was also at the behest of the National Health Mission. It was something that was pushed by the Supreme Court and has then been carried out by the Rashtriya Bal Swasthya Karyakram and the blood cell section of the Ministry of Health and Family Welfare. So where have we gone wrong? Well, we know that most parents, irrespective of their personal beliefs or their religious beliefs, would opt out of a thalassemic pregnancy, but are not aware of the possibility of a prenatal diagnosis. And perhaps this is where we need to correct ourselves, because I firmly believe that all is not lost. I firmly believe that we should not point fingers at each other, and that instead of figuring out what the problem is, we should really find solutions. After all, there has to be a solution. If some countries could do it, why can't we? The efforts to reduce the incidence of disease have been defined and reiterated fairly frequently. The essence of a successful program to reduce the incidence of thalassemia in the population lies in identifying carrier status. And if you're going to be able to do this, we're going to be able to do whatever is best. The whole exercise can be carried out either in an opportunistic manner, which is either in pregnancy or as a newborn screening in birthing centers, which can include primary health centers, community health centers, district hospitals, referral hospitals, and private hospitals. And that doesn't sound like much of a problem. And because, it can be done by medical officers, it can be done by staff nurses, it can be done by midwives. And surely we have a few minutes to advise the test that we need to be doing. It can also be done at a community level by health teams, which visit the Anganwadi centers, our daycare centers, our creches in the cities and the villages, in government and private schools, and in colleges. There were reports that did give us a setback a few decades ago. 3 or 4 decades ago, it was believed that such endeavors of identifying carriers put a label in the marriage market. Thank God society has progressed since then, and we realize that it's a condition that can be handled, and therefore this label is no longer a stigma as it used to be when I was growing up. Surveys have repeatedly shown that there is insufficient knowledge on the detection of carrier status in children, and most of the respondents say that they've not heard the test for detecting thalassemia carrier status. So what can we do? The solution is simple, and I do hope that this evening we're going to debate on this and also come up with whether my suggestions are acceptable or we can take them further or modify them. One is concerted and repeated efforts at community screening, and the second is resensitizing obstetricians and pregnancy healthcare professionals about routine screening for thalassemia as early in pregnancy as possible. What we need to do is to change our approach to identifying the patient with thalassemia. We know that the only thing that works today is an incentive. And the best incentive that we seem to think that works today is money. And I suggest that there should be a cash bonus by the government for every thalassemia carrier identified, and that's all that needs to be done. In the widespread ambience of commercial gain in today's world, this is perhaps the only answer. The amount that goes into the paid incentive kitty will be a very tiny amount compared to the expenditure of repeated transfusions and heterologous bone marrow transplants. There's no comparison between these costs. The second thing, of course, is the emphasis, especially from the perspective of fetal medicine, the need to evaluate all pregnant women with automated rather than the older methods for red cell counts, with confirmation by HPLC analysis for hemoglobin E and other hemoglobin variants. And then the rest of the workup remains the same, which means partner screening for all couples where a woman is identified to be a carrier, followed by prenatal diagnosis as necessary. That really, if we can do to handle all our pregnancies, is something we can do. Yes, pregnancies report late, but we do understand that we can now look for THAL in amniotic fluid, and we just don't need only CVS. And therefore, we can do this at any stage. Thirdly, municipal authorities should not issue a marriage certificate unless a THAL screening has been done. And I'm sure that if we do this, we will be able to overcome our problems. So I do want that we will today debate some of this, come up with solutions, understand our program a whole lot better, and take this forward. Yes, we have failed in the last 2 decades, if I may say 3, but we have the spirit and we have the science, and I think we will take it ahead. And so with this, I open the scientific deliberations today. And I'm so glad the entire Calcutta team and a whole lot of others are here already. And I will first invite Dr. Kanchan Mukherjee, our lead for these 2 years for the SFM Bengal chapter, to set the right context over the next 20 minutes. So over to Dr. Kanchan. For those of you who still don't know him, he has been part of the SFM team right since its inception. a brilliant speaker, a very kind-hearted human being, a leader who knows how to take everybody with him, and someone I enjoy interacting with. He has been a key player for our SFM Bengal branch and is now made it as its president. And thank you, Kanchan, for organizing this program. And over to you to set the right context. We can't hear you. You have to unmute yourself. Yes, and we have to go full screen. Marvelous. We're all set.
Thank you. Thank you for the nice introduction. And you have actually hit the right context already to some extent for me and made my job quite easy by this time. And basically, my job is to explain where we stand. And let me start with a bit of history. Well, ancient literature alludes to conditions which appear to have been caused by thalassemia. And well, the true causes of thalassemia were only determined in the second half of 20th century with a better knowledge of genetics. Now, why couldn't we do it for all these many centuries? Because infant mortality rate was so high that we could not identify the actual causes, and the genetics knowledge was so poor. Now, along the middle part of the previous century, at around 1948, this British scientist Halden came up with this beautiful hypothesis that thalassemia is a natural evolution, natural genetic evolution for the malaria endemic regions, because with thalassemia, what happens is the red cells are smaller, so they are more resistant to malaria parasites. So that was hypothesized that this is a natural evolution. And his hypothesis was supported by the wider frequency of thalassemia in the malaria infested regions of the world. But this has later been challenged because the history of agriculture itself goes 5,000 years back, and malaria came up with the agriculture because people started living in the marshland at around that time. And looking at the wide variance of different beta thalassemia genes and widespread distribution of the disease over the world, it is unlikely that thalassemia has originated from one single place. And the hypothesis has further been challenged in the concept that some of the genes seem to be older than 5,000 years, which dates back the advent of agriculture. So with that, I will now go to why so many different mutations. It makes me wonder why so many different mutations for one particular disease. In fact, EtherGenes, which is a project under Ethernet, a project based in Cyprus, said back in 2014 that more than 350 beta thalassemia mutations have been identified. I'm sure it's already more than that by now. So the reason for this wide variety of different mutations would be in the geographical distribution, history of malaria, history of wars, invasion, and mass migrations of consanguinity, consanguinity, and settlements. Well, what is the global burden? We already know that the high incidence of thalassemia is found in the regions of Mediterranean basin, parts of Africa, in the Middle East, Indian subcontinent, and Southeast Asia. Now, the carrier frequency ranges from 1 to 20%, even though there have been communities where the carrier frequency is as high as 40% in the northeast of India And there have been communities in the Papua New Guinea with a carrier frequency of 80%. Globally, there are at least 270 million carriers with abnormal hemoglobins. And this covers two major groups. One is sickle cell, the other one is thalassemia. Globally, there are more sickle cell disease, sickle cell anemias than thalassemia. And we have about 80 million carriers of beta thalassemia worldwide. Every year, 3 lakhs to 4 lakhs babies are born with thalassemia. In general, the major hemoglobin disorders, and 90% of these births happen in low or middle income group countries. So how big is the problem for India? Well, about 10,000 to 15,000 thalassemia major children are born every year in India. And as Dr. Khurana already said, that 1 in 10 thalassemia major child resides in our country. As you know, the only cure is bone marrow transplant, but the scope is limited with its high cost, limited availability in super specialist centers, and obviously availability of matched donors. So the mainstay of current treatment lies in the transfusion and chelation. Cost of transfusion and chelation is huge. For a 30 kilogram body weight child, for 1 year, it would cost about 2 lakhs for 1 year. And this is a figure in 2008 when this group from the developed group led by Dr. Maman Chandi gave this figure to us. Now, I'm sure it is much higher by now. And then if you have 10,000 children with thalassemia every year, and each child surviving for 50 years, you have to transfuse 5 lakh children at a time and multiply that with 2 lakhs. So that's about 10,000 crores. Now compare that with the cost of screening, where you will be spending only 1 crore to screen 1 lakh people. So you have to really go for wider screening. There is no other alternative. Now, the carrier frequency in India, it is said that average carrier frequency is about 3 to 4%. But studies from West Bengal said it can be as high as 1 in 10. There are higher frequencies in Sindhis, Punjabis, Gujaratis, Bengalis, Mahars, Kolis, Saraswats, Lohanas, and Gaurs. And we do find sickle HBS variant in more prevalent in tribals of southern, central, and western states, reaching as high as 48% in some of the communities. In the northeastern states, HBE is more common and has a higher frequency of up to 50% in some areas. Even though this paper said lower HBE frequency in eastern states of West Bengal, Bihar, like that, but in my personal experience, if I do 10 CVS for thalassemia, out of them 3 will be HBE plus HB beta. So it is not that infrequent even in our practice. In Punjab, there is another variety called HBD, which is found in about 2% people. Now, let's look at the history of our control program. Back in 1997, ICMR and DBT had a so-called brainstorming session on hemoglobinopathies at NII Mumbai, and that suggested a comprehensive program covering each district, extending up to block levels. And I think this is the meeting when they assessed various screening methods like NESTROPT, that single tube capillary osmolality test, and full blood count and all those. And they came up with the idea that hemoglobin electrophoresis or HPLC would be a better method. 2 years later, these patient-parent groups were formed, first of its kind being Thalassemics India, based in Delhi, and that was supported by Thalassemia International Federation. And they started putting pressure on the government, and from that point onwards, the patient advocacy started. In 2000, ICMR started a project called Jai Bigyan. Jai Bigyan basically was a project to create awareness. 4 years later, we see Indian Red Cross Society in Gujarat starting a program among 20 lakh students. They screened 20 lakh students. That was a huge number. And Gujarat has done very well in terms of thalassemia screening and control. 5 years later, we saw the publication of a collated published data on globin gene mutation in India and creation of a web-based registry. That was called ThalInd. Now, I'm glad to say one of the authors of this paper, Dr. Renu Saxena, is here with us today, and we'll get to hear from her during the panel discussion. In 2012, there was an initiation of a pilot project on thalassemia and other births in the state of Uttarakhand. So that was another achievement. And all this history I'm sharing is available in the document that I will be sharing in the next slide. I must mention that even though they have given us a roadmap with different achievements from different places, they missed one thing, that is the Bengal story. I'm aware of a web-based software being developed back in 2010 called Thalamon, that means thalassemia monitoring software, and that is still in use. And that I could not find that piece of information in that guideline. So the question is, do we have a national policy for prevention? Yes, we do, and that came up in 2016. I'm not trying to say that we are wide awake now. I think we are still in deep slumber. As it was stated in this particular document, that in India, we have the technology, know-how, and the means of adequately treat and control, but this has not been incorporated as a policy. So while the Mediterranean countries woke up in the 1970s, at least we finally had a policy in 2016. So that was a big achievement. And the idea was to provide a framework for prevention and management of hemoglobinopathies. So what is the Bengal model? Because I'm speaking from Kolkata, I must share what we are doing here. In the government level, there are 2 nodal centers based in Calcutta Medical College and NRS Hospital. And in the whole state, we have 34 thalassemia control units whose primary job is to organize the screening program. And all these data are going into Thalamon registry, as I mentioned already. And the government has so far been stressing on holding screening camps at government schools, colleges, clubs, etc. But the problem is only screening doesn't really close the loop until and unless you focus on antenatal cases. And I'm glad to say it's only recently that the focus is shifting to antenatal groups, thanks to some of the young hematologists who have managed to explain to the government official that this is definitely a far better method than targeting all other groups. It has to be a holistic approach, but you cannot do without identifying the fetuses affected with thalassemia. So the focus is shifting to antenatal. That's a definitely welcome development. However, I must say, in a state where we have 10 crore people living, you cannot afford to have only 2 centers in the state offering prenatal diagnosis. No other center in the whole state offers prenatal diagnosis. I'm just considering the government units. In the private, many of us are doing this service, but obviously that is not enough considering the magnitude of the problem. So what are the goals of control of hemoglobinopathies? What does WHO say? We have mainly 2 goals. One is to provide affordable and adequate therapy for those affected, and to reduce the number of births of children with disease through political, administrative, and financial support. Now, we, the obstetrician or fetal medicine specialists, we fit in the second group. So we have to be really careful. And as Dr. Khurana said, that this program is to sensitize ourselves about our own responsibility. Now, in this document published in 2010, the NHM guideline for control of hemoglobinopathies in India, What are the different strategies they say to raise awareness? Well, first thing comes is mass communication and media. You have to be present in the mass media and explain what is going on. School textbooks must be targeted, and the school children, adolescent groups can be approached through this method. Interpersonal communication and one-to group communication, whereby through antenatal clinics, through ICDS, you can address would-be mothers. Incorporation of a chapter at undergraduate and MBBS level was suggested, but I think awareness is not a problem in the medics. I think they all know what is hemoglobinopathy is, they all know how to prevent it. Problem lies in the application of their knowledge. I'm not pointing fingers at anybody, but this is what I feel. Now, special awareness campaigns must be arranged to the target groups where you approach the eligible couples, youth, you approach their families, affected children and their families. And in the general community, if you keep on doing these awareness programs, you can boost the myths and misconceptions, because there are so many of these misconceptions around, which I will mention very soon. So what are the different components of control programs suggested by World Health Organization? First thing they say is a strong political will and support and adequate finances. Now, I'm not going to go into much details of that point because you all know how much political will is there in terms of thalassemia control. Optimal treatment of those affected, career screening and genetic counseling cannot be stressed anymore. Prenatal diagnosis, as I said, is not being done enough. The awareness programs and monitoring the program, that's very important, is re-auditing our performance over and over. This is my personal experience. There are some practical problems. The battle remains confined between the caregivers and the affected family. It does not go beyond. There are reluctant asymptomatic carriers and there are persuasion issues. Because thalassemia carrier state does not cause any illness, it's very difficult to bring somebody into your screening center and say, you need this test. Then there are unwilling male partners who might be living at a distance and again, not willing to get tested. Then there is this myth called bad blood myth. Nobody wants to have a child in their family with so-called bad blood. And once you get someone before marriage with thalassemia positive, thalassemia screen positive state, then that might put a negative level in their marriage market. So that is another problem. Next thing is, once they are pregnant, then you are left with a very small window. A lot of the times, pregnancy gets diagnosed at a late stage. By that time, they might be 12 weeks, 14 weeks, if you're lucky. Otherwise, they would come even later. And then there is this limited availability of prenatal diagnostics. As I said, in the government sector, we are only doing this in 2 centers in the whole state. And unfortunately, there is no non-invasive testing methods available as yet. So the impact of thalassemia prevention program worldwide. Now, these days, we cannot say or we cannot recommend anything without the evidence. So what is the evidence that thalassemia prevention program works? If you look at the Cyprus story, if no steps for prevention were taken, then there would be an increase in prevalence of affected births from 1 in 1,000 to 1 in 138. And there would be 600% increase in blood transfusion requirement over 20 years period. So it is that effective that if they did not do anything, then the incidence will be 1 in 138, but they have reduced it to 1 in 1,000 by being proactive about the control program. In Sardinia, Italy, the voluntary screening program has given a wonderful result to them. They started this in 1975 and reduced the incidence from 1 in 250 to 1 in 4,000. In Canada, Montreal, voluntary screening program in high school has given a very good result. and there has been 95% decrease in the incidence, but they started this program back in 1980. So they started about 40 years back. So how effective is screening in various groups? We will look at them in a table like this. Can we screen the newborn for thalassemia? Well, it's not very effective for thalassemia, but it is suitable for screening for sickle cell disease and few cases of thalassemia major only, not for thalassemia minors. Adolescents, very suitable for carrier screening as a long-term sustainable strategy. But the problem is you have to really track them along. Otherwise, the loop doesn't get closed. In our country, it's very difficult to track them along because we do not have a national registry. Premarital carrier screening of at this stage is very effective, and but that needs a very well-informed community, not like ours. Preconception carrier screening is effective in communities where pregnancies are where you would expect the married couple to seek pre-implantation genetics if available. Now, antenatal screening and prenatal diagnosis serves as a net, and this is where I want to stress more and more that in a country where you do not get to catch the adolescents, where you do not get to catch the premarital, and 80% of the pregnancies are unplanned, you cannot really expect them to come to your clinic for a preconception counseling. So your best window remains with the antenatal screening and prenatal diagnosis. This serves as a net to screen those who have not been screened before or who have actually successfully hidden their information, which happens quite a lot in our practice. In both parents, if both parents are carriers or at risk, then there will be, you have to do prenatal diagnosis, and that can be offered through CVS at 11 to 13 weeks or amniocentesis after 15 weeks. And with a more liberal MTP Act in our country, the window is now bigger, the opportunity is there. It's just that we have to apply what is there already available. There is something called Cascade Screening. The screening of siblings and extended family members and members of patients and carriers. This is found to be more effective in adolescent screening in Uttarakhand project. But the thing is, it will require a more concerted effort. It's very good, but in a family where there is an identified child with thalassemia major, people tend to hide themselves away. They tend to distance themselves from that family. So it's very difficult, but we have to break that taboo. Creating awareness, and where do we stand? How are we doing in terms of what we have been doing in the last good few years? This is an example. In the multi-center Joybigyan study back in 2008, they basically undertook a multi-center study in 6 different states. And awareness of thalassemia was less than 5%. That was 0.2 to 4.8% in the cities like Bangalore, Vadodara, Mumbai, Dibrugarh, and Ludhiana. But it was much better in Kolkata, 20%. Then if you look at Kolkata study, I mean, this is a study published by Kolkata doctors back in 2011. They undertook a knowledge, attitude, and practice study, CAPS, they're called, in South 24 Parganas district, where only 38% had heard the word thalassemia, but did not really have the correct knowledge about the disorder. Only 10% individuals in this group gave a positive response that even a normal person could be a thalassemia carrier. So the awareness level lies there. It's really, really appalling. Now we have to think back. Why are we failing? And I'm not talking about the India where most of my audience is coming from. I'm talking about the other India where thalassemia is more prevalent. There are 5 A's. One is awareness or the lack of it. Are we really aware about our own health? How many of us would go for a test where there is no symptoms? Not really. Access or the lack of it. And I mean only 37% of the rural people can access IP facilities within a 5-kilometer distance. Next A comes is absence or the manpower crisis. The absence also happens in terms of numbers, funding, training, equipment, equitable deployment of the manpower, and in the morale. Other staff that we have are really motivated in doing this? Perhaps not. Affordability or cost of healthcare. In a country where they spend only 1% of the GDP on health, how can you expect them to have a successful comprehensive prevention program over the years? 75% of health expenditure comes out of pocket. So if someone is given a choice for getting a thalassemia screening done, for which they do not have any symptoms, why would they go for it? I think the only approach could be where the government takes a policy and gets everybody under this through this screening procedure, maybe in the way Dr. Khurana said, either through their school or in the pregnancy period, or as he said, it was quite interesting proposition that they should not get a marriage certificate. But how many of the marriages are really registered in our country? That's very small. Then accountability or the lack of it. And this can be collective, this can be individual. I've already alluded to individual ones, that a lot of the times we are not applying the knowledge and we are missing out on the thalassemics. A lot of the times we have the pre-formatted, the printed prescriptions where we have a list of investigations in pregnancy. And many a times I see HPLC is missing. There is all sorts of investigations written from APLA to vitamin D, everything except HPLC. And in terms of collective accountability, I think government has to remain accountable as to this. So what is the road ahead? The road ahead is a concerted effort towards education and awareness across the country. Need for micromapping in every state. We have large data on the prevalence of thalassemia carriers from few states, but a lot of this is hospital-based. Privates are totally missing. We have to train in fetal sampling procedures for obstetricians and sonologists, and that has to go out of the major cities. In the big cities like in Kolkata, quite a few of us are doing the procedures, but in the districts, not a single almost. A joint effort by all the state governments supported by the center, along with corporates and NGOs, thalassemia societies, have to be done. And there has to be a proper political backing. So in summary, hemoglobinopathies are an important cause of morbidity and mortality. India has the largest number of children with thalassemia major in the world, about 1 to 1.5 lakhs. We still have 10 to 15,000 babies with thalassemia major born every year. The screening and prevention strategies are effective. If you apply them, they will bear fruits. And there isn't a single screening approach which is gold standards. But finally, if we have to stop a fetus from being born with thalassemia major, it is the antenatal tests. So if you ask me, where do we stress most? I would say the prenatal screening and diagnosis. However, the approach should be multi-pronged, as I mentioned. Thank you.
Thank you. Thank you, Kanchan, for setting the stage for the rest of the evening. Some disturbing statistics, and yet we need to be aware of them to make sure that we can turn them around in our own lifetime. We will have, of course, an audience interaction on all of this at the end of the program. So I know you're going to stay on, of course, it's your own program, and we will discuss some of these features. I now request our next speaker to take over for a screen share. Dr. Ratna Puri needs no introduction. She has been our former president of the Society of Fetal Medicine, the people-friendly geneticist, the person who guides us through all our hassles, the one who makes sure that we get genetics at, if I may use the word, right price. She is Chief of Genetic Services at the Institute of Genomics at the Sir Gangaram Hospital in Delhi. So over to Dr. Ratna Puri for telling us about the pathophysiology and genetics of thalassemia. Dr. Ratna Puri.
Thank you, Dr. Khurana, for the very kind introduction. And I would really like to thank both you as well as Dr. Kanchan to set the stage and introduce a lot of concepts that are really very integral to understanding what is the burden of this disease in our country. So, what I've been asked to speak on is the pathophysiology and genetics of thalassemia. And to put it in the correct perspective, we have something which is referred to as hemoglobinopathies, which includes, so it's something which is not okay with the hemoglobin molecule. That's what it means. And this would include the beta and the alpha thalassemias, as well as certain changes that occur within the molecule, within the globin genes, within the globin chains of the hemoglobin molecule. And that is referred to as a variant hemoglobin. What we talk about hemoglobin S, the sickle, the C, the Lepore, the D Punjab or Iran, and hemoglobin E. So this is just to put a classification in the mind to be able to place them correctly. We do know that this is the commonest autosomal single gene disorder globally. It presents as a chronic hypochromic hemolytic anemia, which requires monthly blood transfusions. And it really impacts the life of not only the child who's receiving it, but also of the family at large. And that is true for all genetic disorders. So we've learned and heard all these statistics, so I'm not going to repeat it. But I think this is something important to understand is that we have a huge carrier frequency, about a mean of which is about 3%, but it varies from 1 to 17%, depending on which part of the country we are looking at. There are specific communities and specific states where the burden of where the carrier burden is much higher compared to the rest. And this also guides us as to what sort of mutations, what are the things that we need to look for if we have a patient from that community. Now, just to understand, this is what the hemoglobin molecule looks like. It has 4 globin chains. So globin is the protein which forms the molecule. There are 2 alpha and 2 beta. And before I come to this, the hemoglobin goes through a lot of development within the embryo and as the child grows. So in the embryonic stage, we have the embryonic hemoglobins, then we have the fetal hemoglobins, and then come the adult hemoglobins. And this adult hemoglobin is of 3 kinds. The major amount is hemoglobin A, which comprises 2 alpha globin genes and 2 beta globin genes, which are all working together. Some amount of it is hemoglobin A2, which is 2 alpha and 2 delta, and hemoglobin F, which is predominant at birth and in fetal life, decreases by about 6 months to 1 year of age to a small amount. And this is the alpha 2 alpha chains and 2 gamma chains. So all this is coded by genes, the beta globin cluster that is present on hemoglobin 11. And you can see it has, so it's a cluster. So there are many genes together. So epsilon is the embryonic one. Gamma is the fetal one. Delta is the hemoglobin A2 one. And beta is the adult hemoglobin one. So this beta globin gene will code for these beta globin molecules or proteins. And on chromosome 16, we have the alpha globin cluster. And it makes it a little more complicated because there are 2 genes here, the alpha 1 and the alpha 2. But this is the predominant gene that codes for the alpha 1 and the alpha 2. Okay, the 2 globins that are forming a part of this hemoglobin. So if something is not functional in the delta or the beta or the gamma or in the alpha, it will result in an abnormality of this molecule and give rise to our group of hemoglobinopathies, which includes thalassemia, as well as the variant hemoglobinopathies, which is sickle cell or hemoglobin E disease. Now, we know that this is an autosomal recessive disorder. We recognize it because we know that most of the affected individuals run in one generation. And in every pregnancy, there is a 25% risk that the baby can have the disease. And pregnancy number 3 does not remember what happened in pregnancy number 2. So this risk of 25% affected is there for each and every pregnancy. And the parents who are carriers, these are the parents of an affected individuals who are carriers, will not be symptomatic. Now, so we know that in carriers, one copy of the gene is not functional, one copy of the gene is functional. Disease will only happen when both copies of the gene are not functional, as you see here. Where we have one functional copy, there will not be disease. So this is the other side, where if one partner is a carrier and the other is not a carrier, there is no risk of disease to the child. The risk will only be there if both partners are carriers of any form of change in the beta or the alpha globin gene. Now we have something which is referred to as thalassemia syndromes. So this is thalassemia major, intermediate, or one of the variant hemoglobinopathies. And as I've already alluded to before, either both partners are beta thalassemia carriers, or one partner is a carrier of an abnormality in the beta globin gene, which gives rise to thalassemia, and the other has a variant hemoglobin gene abnormality. For example, hemoglobin E, hemoglobin S. So all these changes are present in the hemoglobin gene, which is the HBB gene, but they are different kind of changes that give rise to thalassemia and those that give rise to hemoglobin E, S, or D, etc. So what actually happens? What is the pathophysiology? So what if there's a change in the gene? So it's not simple as what we see in other disorders, because here, like I told you, there are 2 alpha and 2 beta globin genes, chains that come together to form the hemoglobin molecule. Now, supposing there is an abnormality or a mutation in the beta globin gene, so this beta globin is not being formed properly, and there is an alpha and a beta mismatch. There is more alpha, there is less beta in this molecule, and therefore this molecule does not form well. The excessive alpha doesn't know what to do, so it kind of like just precipitates. And when that precipitates within the RBC, it causes what is the basis of all the phenotype of beta thalassemia, and that is ineffective erythropoiesis. So if we understand this base, we would be able to understand why the different changes cause disease and why some changes do not cause disease. So I've already alluded to the beta thalassemia phenotypes. Major is where you require a blood transfusion. It starts about the end of the first year of life. And I'm sure in the panel discussion, Dr. Khanna would be talking more about this. We also have what is referred to as sickle cell disease. We have an entity which is called alpha thalassemia, which is present in India. It's not so common in North India. It is reported, of course, it's well seen, but it is not as common as beta thalassemia. And this presents as either a hemoglobin H disease or a hemoglobin Bart's, which is the really severe neonatal or a fetal phenotype that presents as non-immune hydrops. And of course, we have carriers who are not at all symptomatic. And a carrier and a minor and a heterozygote are all the same. Now, we know that there are some symptomatic disorders and the others are not symptomatic. And I'll be talking about them later, but it's important to know this because as a fetal medicine specialist, who are you going to do a prenatal diagnosis for? And that has become very, very important. So now these are the different hemoglobin variants that are observed in India. Hemoglobin D Punjab, D Iran, hemoglobin Q India, hemoglobin C, hemoglobin E and S. We've already heard that hemoglobin E is common in the eastern parts of the country. Hemoglobin E is only significant when it pairs with beta thalassemia because it causes a major or an intermediate phenotype. If both partners are hemoglobin E carriers, which is not so uncommon from people from the East, there is, a 25% chance that the fetus would be a homozygous hemoglobin E. But this is a fairly innocuous disease. It can cause some anemia, a little bit of jaundice, but it is not debilitating. It does not cause significant morbidity. And we usually do not do prenatal diagnosis to ascertain a homozygous hemoglobin E. The second is sickle cell disease. This is common in tribal communities in central India. And you can see the states here. And sickle with beta, sickle with hemoglobin D, sickle with these two, it causes a severe phenotype. Hemoglobin D Punjab is really not relevant except for when it is with sickle. Then it causes significant disease. And hemoglobin D Iran and hemoglobin C are innocuous. So what are the various screening methods? We've heard who all to screen, when to screen, but what do we do for screening and how do we identify a carrier? And I personally believe, and I always say, that just doing a hemoglobin A2 is not sufficient. There are times when, the situation may not be very clear. So when we combine the HPLC hemoglobin A2, which tells us about FSA2, along with the CBC parameters of MCV, MCH, and an RBC count, it gives complete information. In people who are carriers, we expect that the MCV is less than 80 femtoliters, the MCH is less than 27 picograms, the RBC count is higher than for the hemoglobin of that person, and the A2 is elevated. Now, there are various cutoffs. It's either more than 3.5 or 4, and the hemoglobin F may or may not be elevated, and it's usually not more than 4 to 5%, because if we have higher elevations, then we think of different forms of thalassemia. So this is what I had talked about, that these are the symptomatic thalassemia syndromes, except for beta thal and hemoglobin D Punjab or D Iran. And in this one situation, prenatal diagnosis is not offered. In all these, prenatal diagnosis would be offered. The same goes for sickle cell disease. Sickle is severe, sickle beta thal is significant, sickle hemoglobin D Punjab is significant. These are situations where they are asymptomatic and we do not offer prenatal testing. So obviously, if one is a carrier and the other is not a carrier, we don't need to do prenatal testing. Then also for compound heterozygosity for DNE, DN beta thal, SNE, and these other not so common ones, prenatal diagnosis is not required. Now I'm just going to go through a couple of case reports to talk about some of the the facts that have been spoken in my previous slides, as well as those by Dr. Kanchan. This is what is referred to as cascade screening. There are two people affected on either side with beta thalassemia major. In fact, the brother of this individual has beta thalassemia major, which means that both his parents are carriers and he has a 50% chance of being a carrier. Yet the pregnancy goes to an advanced stage before this is addressed. It's because either when we are treating these patients or when we are talking to the families, we don't refer to what is referred to as cascade screening. So if you identify a carrier in the family or you have an affected individual in the family, you must tell them that their siblings are also at risk of being carriers, and the HPLC hemoglobin A2 test along with the CBC should be done. The second is, again, a situation where one partner is a beta thalassemia carrier, if the CBC is abnormal, the hemoglobin A2 is raised, whereas the other partner is a carrier of hemoglobin D Punjab. In this situation, we do not need to do prenatal diagnosis in this pregnancy. So what are the prerequisites for prenatal diagnosis? You need to ascertain the thalassemia carrier status of the couple. You need to identify the mutations in the couple well in advance of prenatal diagnosis. And that's the only way where everything is worked up. You do the test and you give an early report. Once the mutations are identified in the family, then the fetal DNA is investigated for the presence or absence of the two mutations that are present within the couple. That means the mother and the father of the fetus, you would only check for those specific mutations. Of course, these are simple things, but what is most important is pre-test counseling and informed consent of the couple and following all the procedures that are laid down by our Act. So a lot, as you have seen in the slides before, a lot of work has been done in beta thalassemia for more than over a decade. The mutations are well characterized. What is common in which part of the country is well characterized. You can do simple tests, just the ARMS PCR for the common mutations. And if those are absent, then you go forward for the sequencing. So it's important that every lab has their own experience, their own protocol to take forward the identification of the mutations. Now, this is just one, another case which was interesting. So I thought I'd bring it forward. So there was this couple in the USA, and this was the report that the wife had come in, the husband was not there, for a prenatal diagnosis at 11 weeks. They're not very confident about prenatal diagnosis for beta thalassemia. So we have a lot of patients who come to India for this. And you can see that the wife's A2 is high. The A2 of the husband was borderline at 3.7. The cutoffs they used were 3.5. We did not have a CBC, and we had no idea what the MCV, MCH was. So we started to identify the mutations. The wife was identified to have a 619 base pair deletion, but for the husband, we did not find any mutations on the testing that was performed. So a CBC of the couple had been done at a time of sampling for mutation. If we don't have it, we do it as a standard protocol in our hospital. We identified normal RBC parameters in the husband. Now, we do know that this can happen in two situations. One is that he's not a carrier of beta thalassemia. The second is there is an entity which is referred to as a silent carrier, and we all need to be cautious about this. A silent carrier means that there is a mutation in the beta globin gene, but none of the parameters are showing it, or they are very subtle. The MCV may be borderline, the MCH may be borderline, the hemoglobin A2 could be normal, or it could be just a borderline increase. And this is well written about from India. The group of Dr. Roshan Kola from the NIIH in Mumbai has published a lot about the silent carrier status and how we need to be aware, especially where mutation analysis is ongoing. So because the husband was not there, we got the parents of the husband because one of them should be a carrier. And their CBC and hemoglobin A2 by HbA1c was normal, which really goes to say that they are not carriers. And then the A2 was repeated again of the husband along with the MCV, and he was not a carrier. And so the end result of this entire thing is that prenatal diagnosis was not required. So therefore, I said that you must have the mutation profile before you put in your needle and take out a fetal sample, because you must be sure of what you are testing for. So you have to look at the picture in the entire landscape. Just don't, just take it forward and do a mutation testing. You need to be aware of what the HbA1c is, what the CBC is, what is the family history, etc. Now, this is again what I said, a little complex, but important to understand. Here you had the husband who had a very borderline hemoglobin A2. It's not more than 3.5%. But if you look at the CBC, the MCV is very low, the MCH is low, he's not severely anemic, and the RBC count is high. So we know that he should be a carrier. So he was a carrier. In fact, he had a severe mutation, but not associated with a very high hemoglobin E2. So this becomes very important to look at this whole picture and then take it forward. So when we talk about prenatal diagnosis, and I talk a little bit about our experience from my hospital, where we've been doing it since 2000, actually since 1987, but this is old data, just to show that though we are improving in doing primary prevention, that is doing testing before the birth of an affected child, but we still have a lot of children who are diagnosed with thalassemia even today. So this is what we need to achieve. Prenatal testing in the absence of a previous affected child. And this is really primary prevention. And the key to any successful program, as we've heard in the previous talks, is really prevention. That's the only way to curtail it. And that's how the countries in the Mediterranean, etc., have done it. And this is our work in prevention at the center. So you have to screen every woman or couple. You have to do complete blood count, that is MCV, MCH, RBC count with the hemoglobin, along with your HPLC hemoglobin A2. A family history is very important because it can give you a lot of clues. The ethnic origin also is very key. You need to do prenatal testing only if both partners are carriers. The mutation must be identified prior to sampling for prenatal testing. And the recurrence risk is there in each and every pregnancy. So this has to be repeated in every pregnancy. If the mutations are identified once, of course, you don't repeat the mutations, but the prenatal testing would need to be repeated. Thank you very much.
Thank you very much, Dr. Ratna Puri, for simplifying these and also for highlighting that it's not just a question of looking at one odd parameter. And we will have a lot of questions to be answered. They've all come up in the chat box. I know some of them will be answered during the panel discussion, but may I request you to stay on for the end of the program. We now move on to also taking the diagnosis further. And Dr. Kusagradi Ghosh will now tell us which prenatal tests, how and why. He is again someone who needs no introduction, a pioneer of fetal medicine in India, and certainly a very easygoing person, but a brilliant scientist, an excellent worker, and a former president of our Bengal chapter of the Society of Fetal Medicine. He's been a great support for us by spreading spirit in the eastern part of the country and other parts of the world. Thank you, Professor, for always being there. And I look forward to your talk on which prenatal test, how and why. We see your screen, but we don't hear you yet.
Can you hear me now?
Yes, yes.
Okay. Thank you. Good evening, everybody. Thank you, Dr. Khurana. It was a brilliant lecture. First of all, by you, then Kanchan, who is always so encouraging in everything. And of course, by Dr. Ratna Puri. Now we take it forward, slightly forward in the form of prenatal diagnosis, which one to do, when to do, how to do, and why to do, and what are the pitfalls and limitations of each test. So which test to do? To start with, which test to do? What are the tests do we have? We have invasive tests, which we all know, the CVS, the amniocentesis, and the chondrosynthesis. Non-invasive test called the NIPT or NIPS. Highly invasive test, as they call it, pre-implantation genetic test, because we are not entering into the uterus with a needle, but we are entering into the embryo. And gamete donation, which is sperm and oocyte, which is of course not a prenatal test. So these are the options that we have for diagnosis. Now, when to do? As had already been elucidated, that when the partners are carriers, both of them have to be carrier to have an affected child. The risk is around 25%. So that is the first prerequisite to do the prenatal testing. And then Dr. Ratna Puri has brilliantly elucidated the details and the nuances of HPLC testing, how to diagnose, when to diagnose. So that's the first thing. There's a second thing, that this should be done before we know that they're carriers. And once we know that both are carriers, then we go ahead. And then comes this very simplistic chart of the mother being on one side, in the vertical axis baby, and on the horizontal you have the father. And these are the cross sections of different types of combinations. For example, if you see this chart, if you see the beta thal on the left and the beta thal crossing on the top, we have a red square, which means a prenatal diagnosis has to be done. Whereas if you see the hemoglobin E in the mother and hemoglobin E in the father, then it goes to a blank square, which means you don't have to do a prenatal diagnosis. Likewise, if we see hemoglobin E with beta thal, then it comes to E beta. So like that, it goes on. So it's a very simplistic, very interesting chart. I'm not saying this is foolproof, but it does help in the initial assessment by people like us. And sometimes it helps genetic counselors as well. So that is the third prerequisite. Now, why do we do thalassemia testing? That is because it is a childhood disorder of enormous morbidity. The child suffers and the parents as well. Now, around 15,000 of children are born in India yearly, and it's a huge challenge to procure blood on a regular basis. So that's the reason we do prenatal diagnosis to the ones who have fallen through the net of prenatal screening. Now, how to do it? Now, coming to the invasive tests, I should pay tribute to these four great persons I've met in my life, starting with Kypros Nicolaides, and then Dr. Mamta Sanghamita, who has actually provided me patients, practicing CVSs, and of course, sharpening skills with Dr. Suresh and Dr. Kamal Oswal. It starts with a very personal experience, a narration of a very humble journey, seeing the master at play. And somebody asked him at one point of time, Kypros, how can you manipulate the needle? Nowhere looking at the needle, but somewhere else outside with a vacant look like that, but he's very focused. And he always used to say that when you drive a car, you do have the ABCG, the accelerator, brake, clutch, and the gear. And we manage everything. We press and release, and we press again. But then do we look at them? We don't. We look at the road and what lies ahead, and then we drive it. So driving a needle is almost like that. Now, as far as prenatal diagnosis of thalassemia is concerned, CVS is preferred overall over amniocentesis. That is also because of the fact that, for example, in Down syndrome, we are talking of risks of about 1% or 2%, 1 in 50 or 1 in 100 or 1 in 200, like that. But the chance of finding an abnormal finding is very low. So amniocentesis may be done at around 16, 17, 18, 19 weeks maybe. But in thalassemia, where the chance of an abnormal finding is up to the tune of 25%, then earlier the done is better. And therefore, CVS is preferred over amniocentesis. And also in the medical colleges in Kolkata, for example, they are more proficient in doing thalassemia from CVS than from amniocentesis. So that is one of the reasons that another reason why we do CVS more often than amniocentesis as far as thalassemia is concerned. Now, first of all, coming to chorion villus biopsy, CVS as we call. Chorion is basically the name given to early placenta. Their roots can be transvaginal, which again can be transcervical or transfornicial. Transfornicial is the one which is not used. It is used for ovum pickup in case of IVF pregnancies. So people who are doing IVFs are very proficient with this transfornicial, but in pregnancies, we usually avoid that. Transcervical means it goes through the internal os into the placental area, but extra amniotic. And the other one is transabdominal. There are two approaches. One is with the biopsy guide. People who do transvaginal CVS, they usually use a biopsy guide. So there are people who don't use a biopsy guide as well. And but the transfornicial has to be done with the biopsy guide. And then the freehand technique is there. Now, when to do it? it has been noticed, and it was published way back in 1990s, that the analysis of limb reduction defect in babies exposed to CVS, and the conclusion was not to do CVS when the CRL was less than 11 weeks, which is about 45 millimeter, and we do CVS when the CRL is around 60 millimeter or so. That is the maximum number of CVSs that we have done so far. The range is about 11 to 14 weeks. Not that it cannot be done beyond that. Like, for example, when medical college patients comes, then we have to do beyond that. Then it is called placental biopsy. We have even done at 16 weeks or 17 weeks, but the usual time is between 11 and 14 weeks. And there is one problem of CVS, which is placental mosaicism. Now, these transverse limb reduction defects have also been reported by other workers as well. And therefore, as a rule of the thumb, or in fact, in all cases, we should not be doing CVSs below 10 weeks. Now, CVS layout is very simple. We need just a spinocane needle of around 20 or 18 week gauge, some lignocaine for infiltration, and some 10 ml syringes, gloves, etc., and plastic tubes for collection of samples. Now, the first thing is pre-procedure assessment, which is extremely important. Mapping of the placenta is most important to decide the point of entry. The point of entry should avoid the sides as far as practicable, because there are uterine arteries there, and there are case reports where the CVS needle has actually injured one of the arcuate arteries, and hematoma in the broad ligament or branches of uterine artery has been reported. The angle of entry is also important, and therefore we tend to hold the probe as vertical as possible. The depth of entry also is measured, whether you use a shorter needle of 10 centimeter length or a longer needle of 15 centimeters length. So a pre-procedure assessment is very important. We try to avoid the lower segment because the uterine bladder is there, uterine fundus because the muscle is very thick, the myometrium is very thick, and the sides, the uterine vessels, as we said. And we have to better to avoid the scars because the visibility is very poor, especially in previous cesarean section and previous myomectomy scars. The next thing is infiltration of local anesthesia, which we do with a 2 ml syringe with 1% lignocaine anesthesia. And let me close the sound. Okay, can you hear me now? Yes. So then what we do is we infiltrate and we wait for some time, and then we carry on. After infiltration, the next thing what we do is to put in the CVS cannula. So we take out the infiltration cannula, and then we put in the CVS cannula. The CVS cannula is put in holding the left hand perfectly still, and the angling is done. The free hand technique is used, and gradually the needle is guided into the placental area. You can see the needle on the screen. The next is how does it look in the screen. If you blow it up, that's how you see. The needle is there, goes in sharp jabs. The angulation is already decided beforehand because it is very difficult to manipulate angle later on. And then usually it is at 45-degree angle and starting about 1.5 to 2 centimeters away from the probe. And the needle has to be strictly in the mid-sagittal section of the probe. Now, after putting in the needle, what we do is take out the stylet from inside, and we attach a syringe with the media, and then put a negative suction. After putting the negative suction, we do a little to and fro motions, about 5 or 6, and then we take out the needle very gradually. So that is the one which we do, take out up and down about 4 or 5 times. So it takes only around few seconds, approximately maybe 15 seconds or so. So after we take out the needle, then we take out the needle with the syringe. So we don't detach the syringe from the needle. We take the syringe and the needle together and put it in the media. That's how the picture looks from inside. The needle is there, and we attach the syringe with the needle, and we do 4 or 5 gentle movements through the placenta, thick portion of the placenta, and we tend to avoid the cord insertion. So that is something which is mapped beforehand. So once that is done, and that is how, that is what it is. So basically, we have to understand that before we putting in the needle, as Dr. Puri has said very well, that it is always important to identify the mutations first, or the unless we know the mutations, there can be silent carriers, etc., which is beyond my comprehension actually. But unfortunately, what happens is patients come from such a long distance that to take only the parental blood and send it for analysis and ask them to come after 10 days or 12 days again for a second trip to come for the CVS is sometimes very difficult. So women and couple as a whole would like to come immediately on the same visit, just one phone call, just get it done and go away. And there are financial implications involved as well, because the patient has to come up and down, take a leave, etc. So what we do normally is, I mean, this might be debatable also, that we do what is called a cryo-analysis. In cryo-analysis, what we have found out in more than 98% or 99% of cases by NGS, we do find a mutation and the result is available. Now, it can be possible that in 1% of cases or more, the result may not be available because of some delta beta or something like that, which is not picked up by the standard NGS that we do for the beta gene analysis. And then the patient has to come again for or give a consent to not come again. Basically, they have to give consent for further analysis by MLPA and things like that. So therefore, what we do normally is, what we should be doing is take a prior consent that it may not be possible in a very rare percentage of cases, the result to be available by trial analysis, and to avoid that, the only way is to give the mutation analysis, blood for mutation analysis first, and get the mutation analyzed, and then come for CVS or amnio or whatever. So it's left up to the patient. Now, after the thing, what we do is blood group, as we said, already been pointed out by Dr. Puri. If it is negative, then we give NTT. Unfortunately, we don't have 50 microgram or 150 microgram NTT in India at all. So unfortunately, we have to give 300 microgram by compulsion. No, it is costly. It costs around 3,000 rupees or so, which is probably more than the CVS cost itself, but that is how it goes. Blood group antibiotics is again something which is debatable. Personally, I give antibiotics, but there are case reports and there are series also where antibiotics have not been given. Now, having said these things, the involvement of genetic counseling is very important, as has been stressed over and over again, that sometimes with trial analysis reports may not be found. Now, the other one is transvaginal CVS. It has been reported that it increases patient discomfort, bleeding, infection, maternal cell contamination. Yes, we need to do a blood test for maternal cell contamination exclusion as well. And individual expertise, of course, are there. There are series from India, even Raju Saitya, for example, who has published many papers on transvaginal CVS, and it works very well, especially for posterior low-lying placenta and early around 11 weeks or so. We should not be doing below 10 weeks, but there are people sometimes who do, because it is possible to do transvaginal CVS before 11 weeks, which is not recommendable. What is used is olive tip metallic malleable cannula. We used to do transvaginal CVS quite a few years ago, but nowadays we don't. And therefore, what I will show you is a schematic diagram of transvaginal CVS, what it means actually. I couldn't get hold of a recent video. What we do is, what is done is an olive metal tip cannula, which goes into the cervix. So it is transcervical. It is extra amniotic, and it reaches the placenta. Especially in posterior low-lying placenta, very early in pregnancy, this can be done. But this ultrasound probe has to be held by another person. Now, how does the villi look like under microscope? That is how it looks like. You don't need a fancy, any bigger microscope. Just with the naked eye, actually, this is what is seen. And if they are very clean like this, we don't dissect it to shear it off the maternal cells. But if there are, then we have to use a microscope to shear away the blood. Now, how it looks like in the tube, these are the tube with the media where CVS sample is put in, and once we stir a little bit, what we see are floating like fronds of a branch. Now, complications of CVS are pain, bleeding, leaking, infection. Overall, whatever way it happens, miscarriage is about 0.1% in our series, which we have published. Placental cell mosaicism is something which is inherent in CVS, we all know. Maternal cell contamination can be there where the lab may not be able to give the report. Bacterial contamination may be there where we have to transport the sample to another city. Slow growth, insufficient DNA is there, and there is a possibility of resampling and medical-legal implications as well. We did publish a paper. We started doing this prenatal diagnosis from 1999. We published a paper in 2004 in prenatal diagnosis, where you can see Dr. Mumtaz Sanghamita is there. This was a research project which was going on in Rajabaja Science College in Kolkata. And we had some interesting informations from there. The second one is amniocentesis. Very rarely we do amniocentesis, but there are two types of amniocentesis. One is early amniocentesis, another one is late amniocentesis. Amniocentesis between 12 and 15 weeks is called early amniocentesis, which we avoid because we all know that the amnion has not yet fused with the uterine and the placental wall, and there is always a little bit of extra coelomic space. And if we put in a needle through that space, which is all around, it is seen posteriorly and laterally, but it is also there anteriorly as well. And once a needle goes through that coelomic space into the amniotic cavity, nothing happens as such. But when we take out the needle, there is a possibility of amniocoelomic fistula, and constantly amniotic fluid may leak into the coelomic space and come out of the cervix. And there can be oligohydramnios, which has been reported. Apart from that, there are other problems that the amniotic fluid quantity is very small and therefore may not be suitable for giving a report. And there are increased rate of fetal losses as well, apart from later on oligohydramnios. So that's why early amniocentesis is something which is not done these days. We normally do amniocentesis after 16 weeks when the amnion has fused with the uterine wall decidua. So the main thing is basic assessment of amniocentesis, why we are doing, you all know the indication, when, after 16 weeks, why we know. Pre-procedure USG assessment is almost same as we have discussed before in CVS, but we have to map the placenta to see whether we have to go transplacental like what we have done there. If we have to go transplacental, we have to be extremely careful not to do any side-to-side movement of the needle, because there is always a possibility of sharing some of the blood vessels or capillaries over there, which we may not be able to see and may not be able to see on Doppler also, but it causes maternal cell contamination. Posterior placenta is easier because you don't have to go through the placenta. So, and we usually keep the bladder empty. In CVS, for example, we keep it half full. In posterior placenta in CVS, we keep it empty, and in anterior placenta, we keep it half full. Now, the amniocentesis layout is exactly same as in CVS. There is no extra thing required. And again, what we do is we use a double glove technique. We this is something which I learned from Professor Suresh. Instead of using fancy endocamera probes that we use in laparoscopic surgery, we can just use a double glove technique and then use it for sterility. It is done in the OT with dripping and dressing, and that's how it is done. The needle is entered exactly the same way as we did in CVS. In fact, it is easier, but it's important to visualize the shaft of the needle throughout the procedure. If the tip is lost, we have to reorient it, make the tip visible, and then go into the circulation. And we see stay away from the fetus. Now, after we put in the needle, we attach the syringe, and we dispose of about 2 ml of fluid, and we use another syringe, a fresh syringe, to take 2 10 ml samples, because sometimes DNA sufficient may be insufficient. But yes, sometimes we do take 10 ml sample as well. Now, after the thing is done, we take out the needle again under guidance. So at no point of time do we lose the needle, because if we lose the needle, there is always a possibility of hitting a vessel in the cord or the fetus itself, which is dangerous. And that is how amniotic fluid looks. So two samples per patient, that's what we do. And now in twin pregnancy, it's very interesting, because first of all, we have to know it's monochorionic or dichorionic. And if it is monochorionic, we can sample one of them. But in dichorionic, we have to number the fetuses. Nomenclature is very important, A and B or 1 or 2, whatever we say. And that we all know, that's a different story altogether. So we put one needle in one sac, keep it there, we don't take it out, and put the other needle into the other sac, making sure that we are going on either side of the two amniotic separating membrane. And proper labeling of the twins is extremely important. Usually label it, we can say right or left, but we normally also add added features like placenta anterior or posterior. We don't usually write the sex, but anterior or posterior, and right or left of the mother, or up and down. So these are the different nomenclatures that we use. Because sometimes what happens, unfortunately, one of the twins comes normal and the other one comes thalassemia major. And unless we have marked them properly, we may actually do a selective reduction of the wrong fetus, which is a disaster for the patient, disaster for the doctor as well. So after amniocentesis, we show the heartbeat to the mother, reassure, checking the TRF, the test requisition form is very important. PCPNDT forms need to be filled up, antibiotics we give, rest for a couple of hours, rest at home for 1 or 2 days, and we always give an emergency contact number in case there is a problem. The problems, complications are same as in CVS, except the placental mosaicism bit. Now comes the photosynthesis. We almost never do photosynthesis for thalassemia because they usually don't come late. We have only done about 2 or 3. Suretake or Chiva needle is used, 22 gauge, 15 centimeter, single-use needles with markings to make it more visible on ultrasonography. We need syringe and connector. Connector we don't need. Connector we need only for blood transfusion. So assessment before photosynthesis is important. Anterior lateral placenta, we go with umbilical vein at the placental insertion. And if it is a posterior placenta, the site of photosynthesis would be the fetal intrahepatic part of the umbilical vein. This is obviously a slide from transfusion. This is a photosynthesis layout. So we don't need to paralyze the fetus or anything like that, but this is hardly used for thalassemia. So this is the team for any invasive tests, though, whether it may be CVS or amniocentesis or whatever. And we should not forget the patient also, because we keep on talking to the patient. It takes about maybe 5 minutes or so, dressing, dripping and everything, maybe 7 minutes. But during that time, we constantly talk to the mother, make her relaxed and reassure, and show her everything on the screen so that she's also involved. Now, this is a thing on photosynthesis. I think I will just skip it maybe. Just the needle, it goes into the intrahepatic portion of the umbilical cord, umbilical vein, and that's where we take the sample from, but not for thalassemia usually. So I'll skip these slides and straight go to another section, which is the pre-implantation genetic diagnosis. Now, this is something which is really picking up these days. Whether it is there or not, that is something which we need to understand. PGT, the terminology is no longer used. PGT is called the pre-implantation genetic test. Previously, it used to be called pre-implantation genetic diagnosis. So PGT can be PGT-A, which is PGT aneuploidy, PGT-M, which is PGT monogenic diseases, of which the commonest is thalassemia, which I'm going to discuss in next 3 or 4 slides. PGT structural problems, PGT mitochondrial DNA, PGT HLA mapping, especially when there is a severe child involved, which is going to come a little later. So that is what it is. And In thalassemia PGT, PGTM, or called monogenic diseases, the interval between the ovum pickup, OPU as it is called, and embryo transfer, that is what is used. Mostly IVF go for cryopreserved cycles, and therefore we have ample time to do a PGTM before putting in the embryos. Blastocyst stage is the one which is used in embryo biopsy. It is called hybridization technique. This technique is entirely different from the normal NGS that is done, and Dr. Puri might actually go into details about this. I don't know much about it. The results would be that if both alleles are present, as usual, the embryo would be affected. If one allele is there, then it is carrier, and none are there, then it is normal. The sensitivity is low because the number of cells that we can take in embryo biopsy is only 2 to 4, but these days people are even doing the single cell biopsy. And follow-up has to be done with amniocentesis, because with pre-implantation genetic diagnosis testing, we cannot be 100% sure, and there is a possibility that the result may be wrong. The major advantage of PGTM is that the woman did not go through abortion in 25% of cases. The major disadvantage of PGTM is whether it is cost effective and the complications of IVF involved and the success rate of IVF involved. And it is considered as a highly invasive test, which we already mentioned before, because people may think that it is not invasive, but it is actually more invasive because we're invading the developing embryo, and we really don't know what is the effect of that invasion would be, because there are some disturbing case reports which has not been validated, but we have to watch the space regarding PGT. The pros and cons of PGT are the couple usually are not infertile, so they have to go through an IVF in spite of the fact that they are not having any problem in conception. The complications of hyperstimulation, which is the dreaded complication of IVF, is always there, though it has come down with anti-gonadotropin cycles. Failure to ovulate at the level of the ovum pickup time is always there because of poor quality. Failure to fertilize, either because of poor oocyte quality sperm or the media quality. Slow growing embryo, either at the embryonic stage or modular stage, or blastocyst is there. Implantation failure is a very big problem with IVF these days. Even if you have a very good embryo, then when we transfer the embryo into the uterus, it just doesn't stick, and all the money goes down the drain. And there are instances of RIF, which is called recurrent implantation failure, which is almost equal to recurrent pregnancy loss. So they are the same spectrum almost. And there are, of course, after that, biochemical pregnancy and miscarriage rates. So there are questions regarding overall take-home pregnancy of women who enter into the IVF cycle, and especially the IVF PGT cycle, and the congenital malformation, some publications, as we said. And along with PGTM, PGTA is recommended because we need to know about aneuploidy also in these patients. And after everything, amniocentesis is something which is the gold standard, has to be done. But the chance of finding any problem in amniocentesis is extremely low, though. Now, to circumvent these problems, the new technique which is coming up is non-invasive PGT, or it's called the NIPGT. And we have to have the concept of SCM, which is the spent culture media, which means in the IVF Petri dish, the embryo is growing, and from that embryo, DNA leaks out into the media, and from the media, DNA of this spent culture media can be harvested and analyzed rather than doing an embryo biopsy. Now, the question is whether this media DNA is representative of the embryo and whether there could be mosaicism also. So these are the questions which have to be answered. This is still in the research phase, but because it's an SFM webinar, so I thought for completeness sake, I mentioned that. The limitations of PGTM are consanguinity, less number of cells, STR analysis required, pedigree samples are essential, one generation up or down, germline mosaicism is always a possibility, and the problem is pseudogenes are always there, and therefore they have to be followed up by prenatal diagnosis by amniocentesis or CVS. The suitability in these PGT cases, we use amniocentesis rather than CVS. The suitability would be if the couple has a problem. So who are the patients who might benefit from PGTM? People who are already having problem in conception, infertile couple who are financially solvent, because on top of the IVF cost, one has to go for, and the complications. Always we have to test all the embryos for this PGT, which is costly, and after that throw away a few embryos, and of the remaining embryos, if they're only of good quality, then only they will succeed. People who are having needle phobia, getting against, and who are completely against getting an abortion done. So those are the patients who are suitable for it. And there is a new concept of a savior child, where the couple decides to have another child who would give the stem cells for the treatment of the existing thalassemic child of the same couple. But for that, we have to do a PGT-HLA matching as well. So it is PGT-M, PGT-A, and PGT-HLA matching. But it is being done some centers in the world. So everything needs to be counseled properly. Now, the last thing that probably is going to show the light is non-invasive prenatal screening. There are some papers and the monogenic disease. We know non-invasive prenatal screening is there, or NIPT is there for aneuploidy, but for some monogenic diseases, it is there as well. And thalassemia served as a very good disease model for these experiments. And the one which has been really shown to be beneficial is NIPT can be used to exclude paternally inherited fetal mutations in the maternal serum. So if in the maternal serum, no paternally inherited fetal mutations of thalassemia are found, then we know that the fetus could be either a carrier from the mother, or if they don't inherit from the mother, it will be normal. So in 50% of cases, baby invasive tests could be avoided. And there are two techniques which I really don't know much about, RMD and RHTO, but it is maybe becoming an affordable option in prenatal care. There are systematic reviews of published literature as well. And since 2002, the sensitivity specificity of excluding paternally inherited mutation of thalassemia is quite high. So NIPT for thalassemia, PND is becoming faster and more sensitive. It's still under research setting. Confirmation by invasive test has to be there, has the potential to reduce invasive tests, but there is a problem with low fetal fraction. Whatever we do, ladies and gentlemen, it is a very satisfying experience when at the end of it all, the mother goes home with a normal baby, of either in a family who already has a thalassemia child or doesn't have. So the take-home message would be a prenatal diagnosis may go from invasive to non-invasive way, whatever it goes, but we should be used, whatever we use, very appropriately in the appropriate patient. Prevention is always better than the cure, and we should never forget to do the HPLC, which Kanchan started the first lecture with. And thank you, ladies and gentlemen.
Thank you. Thank you very much, Dr. Kushagrati Ghosh, for taking us through that hands-on experience of how to do a prenatal diagnosis at various stages. And thank you for also warning us that currently PGT-M and NIPS for thalassemia would require reconfirmation with an invasive process and are not going to be managed without an invasive process during pregnancy. I still remember when we started our chorion villus samplings in the year 1985, we were very terrified. They were all cervical approaches those days, but it's nice to see that we grew up by the time the 2000s came along and we managed the transabdominal approach. Now we move on to, if you could please stay on till the end, there's lots of questions for you in the question box, and Dr. Aparna Sharma and Kanchan will take them up at the end. So please do stay with us. A few minutes for our trade partner presentations and then on to the panel discussion. Welcome back, and we come to the second half of today's program, which promises to be as information-packed, and I'm sure each one of you who has stayed on will enjoy that. It's a panel discussion on thalassemia and pregnancy from theory to practice. It's being moderated by Dr. K. Aparna Sharma, who needs no introduction because she is the secretary at the Center for our Society of Fetal Medicine. She is from the All Indian Institute of Medical Sciences, and part of the fetal medicine division there. And she will take us through questioning our panelists, Dr. Chinmay Rath, who is a well-known fetal medicine specialist, has been all over the country and has finally settled down in Telangana, where she currently heads our regional chapter. Dr. Vandana Mansal from Mumbai, where she is known as an institution in her own right as a fetal medicine specialist. We have Dr. Vinita Srivastava from Blood Cell, which is a part of the government machinery to ensure that thalassemia moves on. And she was one of the pioneers in pushing the policy that came up in 2016-17. And I would like to personally thank her for joining us this evening. We have Dr. Virendra Khanna from the Gangaram Hospital, who has worked with thalasssemic children since ever. Every thalassemic in my family goes to him, continues to go to him, and thanks to him, they're alive today. He's helped families out tremendously, not only in India, but all over the country. Thank you, Dr. V.K. Khanna, for joining us today. And we also have Dr. Renu Saxena, who is from the All India Institute of Medical Sciences with a background in genetics, and will throw some insight there. So over to Dr. Aparna Sharma for thalassemia and pregnancy, from theory to practice.
Thank you very much, sir. And I will start the panel now. And I must say that today we really have our esteemed panelists to throw light on some of the practical aspects, though I must say that a lot of it has been covered. But as I said, it is from theory to practice. So let us see, how do we interpret this in our day-to-day lives, and, how to get on with it. So when we talk about hemoglobinopathies, so we've heard a lot about hemoglobinopathies, hemoglobin structure of the hemoglobin chain. But my first question, I would like Dr. Chinmay to answer. Why should we screen for beta thalassemia? So the point here is something like the aneuploidies. I'd like to take that analogy from the Down syndrome screening, that, it is something that may not manifest in the fetal life. So why the screening becomes very important? Can we detect it? And, and what is the basis for doing that? So Dr. Chinmay, please. Dr. Chinmay? She had joined, I believe. Yes. Dr. Chinmay, you need to unmute.
Yes, Chinmay, we see you, but we don't hear you yet.
Can you hear me now?
Yes, now we hear you clearly, loud and clear.
Okay, I'm sorry, I was on the thing. So thank you for bringing this program together on this extremely important topic. And just as you said, Dr. Aparna, the reason for screening is because the problems do not manifest before birth. And if we do not screen, we will not be able to pick up which are the fetuses which are likely to have the condition of thalassemia. And as has been discussed in the preceding lectures, we have realized that this can be a very huge burden of disease on the individual as well as the family. And it's a very, very preventable disease if we are able to pick it up on time and prevent the birth of a child with a major hemoglobinopathy. Now, you've given an analogy of the Down syndrome screening for that matter, and therefore everybody should have an opportunity for screening, because the whole purpose of screening is to screen normal individuals. So like Dr. Kanchan said, the HPLC should become a routine in antenatal care. And if we screen the mothers by a basic HPLC, we will at least be able to pick up those at high risk of having, possibility of hemoglobinopathy in future. And that is very important. The ones like alpha thalassemia, of course, will present early, and whatever the outcome, it will not be a lifelong burden on the family. But beta thalassemia can be so subtle that it may not present initially, and thereafter, if the baby requires all the support that every thalassemic requires, it becomes something as a lifelong challenge.
Yeah, so thank you, Dr. Chinmay. And I wanted to just bring up this fact because, like Dr. Ratna Puri also insisted that, we have to diagnose in babies, in families without a previous affected baby. And that is the point where the universal screening comes so much into play. Now, just talking about a scenario. So this is this primea gravida, about 9 weeks of pregnancy, who presents with this, CBC report. This is from our institute, and here we talk about the hemoglobin, which is 7 gram %, MCV is 58, MCH is 16.7. The RBC count is 4.18. So getting this count is not difficult in most of the places unless we talk about the very basic setups, but in our routine practice, I think we can get all of these. So now I would like to request Dr. Renu Saxena ma'am to talk about screening for thalassemia in all practical aspects, and also the feasibility in low resource settings, the practical aspect on how you would interpret this and how do you go about it.
So maybe I can first start with interpreting this and then go on to the tests.
Yes, ma'am.
So if we look in this particular case, hemoglobin is very low. And if we look at the RBC count compared to the hemoglobin, it is extremely high. And MCV is low, which kind of substantiate what we are thinking. So a low hemoglobin with unusually high RBC count is highly suggestive of a heterozygous beta thalassemia. And if that be so, it is further substantiated by low MCV. And if we were to therefore look at the various indices, which I'll be talking about, we can double confirm it. So now we go on to the next slide. So it's been amply covered that we need to look and diagnose thalassemia carriers, that is the heterozygous beta thalassemia, if we have to look for prenatal diagnosis eventually. So whereas this is possible in centers where there is at least a CBC available, and preferably if there is an HPLC available, but if we have to go into the villages where these facilities are not available, or in fields where these facilities are not available, previously we used to use Nestroff test, which was also mentioned in the earlier talks. And this is a very simple test which can be done by naked eye. Next, please. So this, you take a tube and you just put a drop of blood and you look whether the line which is behind the tube is visible or not. And the person can be trained to read it. And therefore one can identify whether there is, can I have the next slide, please? So this is a test which has a reasonably high sensitivity. And for screening, we need a high sensitivity test. And this had above 90% sensitivity. Specificity was not as good. We don't expect a screening test to have high specificity. The problem with Nestroff was it was so subjective. It was dependent on observer. There was a lot of observer variability. And therefore, that is where this test fell into disrepute. Yet in fields, this is probably the only test that's available as of now, till we have more POCs that become available. So if it is positive, then it is highly suggestive of thalassemia minor, and one should go ahead and do an HPLC if it is negative. And then one needs to also rule out iron deficiency, which can confound the interpretation of Nestroff's, sickle cell disease, and other hemoglobinopathies, which confound Nestroff's. So we come on, therefore, to the indices. So as I told you, low hemoglobin, unusually high RBC count, low MCV are highly suggestive of thal minor. We have certain indices which can be calculated, like the Menser's index, which takes into account MCV and RBC count, Schein-Lal index, which again takes into account MCV and MCH, and Fraser index, which again takes into account MCV and RBC count. Yet in real practice, we seldom resort to this. We just look at the MCV, which is low. We look at the hemoglobin, which is low, and we see RBC, which is unusually high for that particular MCV. And that's how we take a decision. But if there's a borderline case, one always can fall back to indices.
Right, ma'am. So, so this particular patient, as you just said, so we calculated the indices and we found that the Menser index, just an idea, just to take an idea, was just borderline.
Right.
So,
Right.
you know, so this patient was advised HPLC. So this is the HPLC report.
Yeah.
So can you guide us practically on, you know, how to go about this?
So in an HPLC report, we look at the various hemoglobin subtypes. You look at HbA, look at HbA2, look at HbF, and look at HbC, D, or Q India if it comes. So basically here what we see is that HbA2 is 4.2%. As was told earlier, anything above 3.5 or 3.9 in some instruments, you take it as HbF is normal, it's 4.2%. We have to keep in mind that values between 3.5 to 9 of HbA2 are suggestive of beta thalassemia. Any value of HbA2 which is beyond 9% is suggestive of an E hemoglobin. So there it can be E trait or it can be E homozygous. So this is just a chart which says that hemoglobin A2 value less than 3.5 is normal. Between 3.5 to 9 is, of course, a borderline, which can happen in India because we have very often beta thalassemia associated with iron deficiency, and there could be sometimes interaction of alpha and beta thal both together, or sometimes in megaloblastic anemia, you can have borderline high A2. But definitely A2 more than 3.9 to 9 is suggestive of beta thalassemia. So if it is in the borderline state, you have to supplement this with the HPLC, with the mutations, and then take a call on it.
Yeah, so thank you, ma'am. So this particular range where we see it between 3.9 to 9 is beta thalassemia trait, and that is what we are looking at. And then it requires further testing and this thing.
Yes.
So, ma'am, there was this question which talked about which is better for HPLC or electrophoresis, ma'am. So would you like to comment on it now?
So we've used both. We have to go forward with times. Electrophoresis is very labor intensive and time consuming. And plus it depends what you are doing it on. If you only do it on an agarose gel, you cannot quantitate. If you do it on a cellulose acetate paper, you can quantitate, but it's so time consuming. And we move on to newer technology. HPLC is better. It gives you a better representation. Percentages are there. So I think we need, if there is an availability, do an HPLC.
Right, ma'am. So that is clear there. If we are the HPLC is available, we go for HPLC. Yes. So now we move on to the next scenario where there was this fourth gravida para 3 live one with both parents having trait. First pregnancy, baby developed jaundice and died. The second was diagnosed to have thalassemia major at 6 months, and the third pregnancy, this baby developed jaundice later, diagnosed with beta thalassemia and expired at 1 year of age. So, Dr. Vandana, now, how would you counsel and proceed for prenatal diagnosis in this case?
So from her history, I understand that there has been thalassemia major in 2 babies. So the implication is that the parents have to be carriers if the index case is thalassemia major. So first, the counseling is that both of them should be carriers and we need to test them. And second, if we have a child available as the second child is available, we could test the index child for molecular testing. And so we could do the index child alone, or we could do the index child with the parents. Parents will definitely have the carrier setting. And so the risk of recurrence is going to be 25%. So now if this patient is come in early pregnancy, I would get the molecular testing done for the index child and the parents, and get to the which mutation is causing it. So basically now we are more doing sequencing rather than looking at only the 5 common mutations. And once we have the mutation in hand, we could do a CDS at 11 to 13 weeks of gestation and confirm the mutation.
Right. So Dr. Vandana, as you said, so this mutation testing was done and these mutations were identified in the parents, right? So as you said, so we go ahead and do the CVS and the report of the CVS. So I'd like to just you to talk about, that what is this condition and, would you like to, how would you like to go ahead with this?
So this is a report of a mutation analysis where the parents have been tested. So the mother has got one particular mutation, which is a thalassemia minor, and the father again has a 619 mutation, again a minor. But the fetus which has been tested is called as compound heterozygote. So it is a double mutation of the parents, and so will present as thalassemia major. So this patient, the child which we have now is a thalassemia major, and we need to counsel the parents about the implication of thalassemia major.
Right, and we go for a termination. We maybe offer a termination because this baby is going to be affected. And in another patient, again, so this situation where, you know, there was this mutation detected in both the parents, but this particular fetus has a different report. So how would you suggest?
So this is a carrier status for this fetus because the fetus has inherited the mother's mutation but has not inherited the father's mutation. So it is like a heterozygote and like a carrier state. So this fetus is a carrier which will not have much problems and can be continued. Only thing is when this fetus gets married to somebody else, we need to test the carrier of the.
So maybe, I mean, so this is not a place where the fetus is carrier. So we can continue with this pregnancy and provide adequate counseling to the couple that it is important that this baby is further followed up during pregnancy and, you know, when this baby is planning conception. So that was about the prenatal diagnosis. Now we come to the other part which Dr. Ratna Puri ma'am had covered to some extent in detail, but there's still some questions in the chat box. So this lady here, she's a second gravida with previous one baby who had an IUD at 8 months complicated by breech and APH. Not really related, but she's having heterozygous hemoglobin E beta thalassemia. So this is a patient, normally we do come across such reports, and father is having a normal HPLC. So I would now request Dr. Chinmay to talk a bit more in detail about, you know, the practical aspects of clinically significant thalassemias which require prenatal diagnosis.
Now, this particular situation would be one where the mother would have very, very mild phenotypic presentation, because the father is completely normal. And if you look at the fetal prospects of inheriting thalassemia, I think we don't need to do a prenatal testing in this particular scenario. So from the prenatal diagnosis perspective, I think we are okay here. But you have given a history of a previous obstetric event, and here I would like to bring to the notice of the obstetricians that everything that has a background of thalassemia need not be related to the thalassemia, because although the mother has an HPE beta thalassemia phenotype, this condition could have happened to anybody, and the fetal condition was not related to that. So because there's a lot of panic which comes across whenever we see situations like this. So here we would not be offering prenatal diagnosis, and I think you would agree with that. But in any situation where both the parents are heterozygous for the condition, then we need to do a prenatal diagnosis. In some conditions, we have mothers who are very severely affected, like, you know, the mother has either a major thalassemia or she's an HBS, HB thalassemia carrier. But if the father is normal, then also we don't need to do a prenatal diagnosis. However, if we have situations where they are carriers of different mutations, like the mother is a beta thal minor and the father may be not for beta thal, but he may be a sickle cell carrier. In those situations, again, the unusual combination of having a compound heterozygote kind of hemoglobinopathy. So I think because we have to understand the inheritance pattern of these diseases, and they are inherited only when two abnormal genes are inherited, one each from each parent. So if one parent has two abnormal genes and the other has two normal genes, then we need not worry. But if both the parents have one abnormal gene, then also we have to worry. And if they have abnormal genes of different types, then also they could come together as compound heterozygotes. So you've presented a very comprehensive list of conditions where we would need to do that. I think everybody needs to go back and get used to that concept first, and then in every individual case, look into the exact genetics and decide whether or not this is a candidate for prenatal diagnosis.
Yeah. So thank you, Dr. Chinmay. And this particular list, Dr. Ratna Puri had also shown the first part of it. This particular list is available in the 2016 document, which has been prepared by the government of India. And they have really, I think a lot of people here have actually gone into making that document. So it is a beautiful document which lists out. So whenever we are in doubt, you can go back to this list and see, okay, whether this couple needs a prenatal diagnosis or not. This is something that there is so much confusion on, and all the fetal medicine people and obstetricians will agree to me when I say that, you know, couples coming with various hemoglobins, do we do a prenatal diagnosis, do we not? And most of them are presenting to us late. So then the, you know, the guilt part becomes more whether we have missed something or not. So let's go back to this list again and again and confirm whether we need a prenatal diagnosis again or not. Now, before I go on to a clinical case of management of thalassemia in pregnancy, we have with us today Dr. Vinita Srivastav, who is you know, really working towards removing thalassemia from India. And, you know, a discussion with her for 1 minute and you feel so energized and, you know, really taken away with her passion towards thalassemia, working towards thalassemia in India. So I would like to invite Dr. Vinita Srivastav to talk about, you know, the national programs from the perspective of an implementer. What have we done and what can we do and where are we lacking? So Dr. Vinita, please.
Thank you, Dr. Aparna. Thanks a lot. And I can see Renu ma'am and other people who are my guide, I should say. So when we talk about hemoglobinopathies, there's something interesting to tell that when we started with the guidelines, Renu ma'am was one of the key participants, Dr. Tulika said, and other people who guided me well for coming up with this policy and to initiate the interventions at the national level. So if we see how much we have come so far, it is really difficult to define, because still, if I say on my own way, still the screening part is lacking. We don't have the data as such. The screening, if you see what ma'am was telling me about CBC and other things. So we have put it CBC across the country, but somehow the gynecologists are not telling them or to go for HPLC, or the CBC is not being taken defined properly, I should say that, because people are not able to go for HPLC, though we have HPLC facilities in the country, but still it is a challenge that hardly pathologists are able to read it. And ma'am will agree with me, and you all will agree, if you see, go and see the peripheries, it's very difficult to get the HPLC done in a proper manner. So that was a big challenge for me. And when we were talking about these hemoglobinopathy screening, so if you see now the state of MP and other places we have started, and the best part is now we have point of care with us. That is the one important thing which I should emphasize, that now point of care are there, which like in sickle cell, there are 3 point of cares which can do good sickle cell screening. And for thalassemia, there is 1 point of care which can do thalassemia as well as the sickle screening. So both screening can be done at the peripheral, and the ASHA and ANMs need to be trained, which is a very easy screening can be done, and you can get to know the confirmatory test. So this we started in 2016-17, and I think ma'am might be remembering, Renu ma'am might be remembering about it, we sent it these kits to the ICMR to validate, and after validation in some states and by the ICMR, NERTH and NIH, now the kits are ready for the use. So this will be very helpful. Regarding the data, which is again a big challenge for us. So once this point of care tests are there, the data will directly go into the cloud. And once the cloud have the data, then we will be able to know how many people are of the trait and how many people are for the disease. So these things are very important, because hardly people are aware of when we talk about prenatal and other things, which are very highly skilled things and which need to be in the tertiary care. We also need to have the data in a proper shape, and across the country the data should be merged with RCH data also, because when we talk about antenatal screening, it is important that RCH should go for the screening, which is very important. And the gynecologist, apart from the 5 screening, the 6th screening needs to be written over there, which has not been done. So the time is to sensitize these ABOD people, so they come up with the screening in each and every woman who is coming to the facility in the first trimester, which is very important. Regarding the prenatal diagnosis facility, once the HPLC has been done, then only we can go for the prenatal. And but from the government side, I would like to inform that we are coming up with prenatal diagnosis facilities in all the AIMS. all the medical colleges and the tertiary care units, which is very, again, an important aspect, which we are planning to do it in another future. And this will be taken care by the MOTA, Ministry of Tribal Affairs, because Tribal Affairs has come up with the roadmap for sickle cell disease and the training module, which emphasize on these aspects. So these are the important parts which we are thinking. And regarding the management part is equally important about the thalassemia. We have these ICHS centers, integrated centers for hemoglobinopathies and hemophilia in these states. But somehow I could say that these are operational to give the blood transfusions and other things, but not the proper management. If the spleen enlargement is there, then people will not be able to take care of the kid. That is a big challenge. So the referral mechanisms are being made, which is very important in this aspect, that the referral should be there. Where, because we cannot have that much trained manpower at the district level. You might have seen our district level hospitals, as you all are aware of it. So the district level hospitals, doctors need to be trained in such a manner that they are able to take care. But still, till we have all these facilities in our place, we need to have a good referral mechanism which can be taken care by the tertiary care hospitals. Regarding the bone marrow transplant, we also initiated one Thalassemia Bal Seva Yojana with the CSR activity under the CS with the Coal India, where now 200 children had been transplant. And Dr. Khanna is there, so he might be able to tell you, because Thalassemics India was the coordinating body, and we were not getting any money from the Ministry of Health. So it was one of our additional secretary who decided that this should be under CSR. And I was sent for this meeting, and fortunately, with God grace, we got this project. And now this has been running successfully across the country for the bone marrow transplant. But this is only with the siblings, not with the unmatched donors. So this is again a challenge. But for prevention, again, I will emphasize that we need to have a good screening system across the country, which is very important. And I find that still it is lacking, and country is lacking behind into this. But maybe in another 3 to 4 years, coming years, or I should not say 4 years, rather I should say about 5 years, we will be able to establish a good screening system, and we will be able to reduce the graph of children who are newborns to this disease. We will be able to curb the graph of the hemoglobinopathies. With these words, I would say that we have very good experts, and I have been hearing everybody, and all are my guides, I should say, because I have been learning from you people every day. It's not one day, it's like every day. Today, when I was talking, yesterday I was talking to Aparna, it was a good talk. And it was a learning also, what exactly people want to learn. This is very important. We have a very good webinar today, actually, Ministry of Travel Affairs had, and there we have JS Education, we have JS basically disability, and we have WCD also. So now the convergence time is there. We need to converge with every department if we really want to get rid of this problem. Because education people can put up in the screening. What we have demanded is that now education people should, when these students are coming for registration, they should get themselves screened. Then the second thing is with the nutrition, where the WCD is taking care of the nutrition. So nutrition is like that every child who is suffering from thalassemia should have a good nutrition, because it's equal to its diets are equally important to his management part, which is one of the part of the management which has not been taken care. Actually, we only talk about the medicines, but we need to take care of the nutrition as well. And thirdly is the Ministry of Social Justice, which talk about the disability. So now disability department is also giving scholarships to these kids who are suffering from this disability. So thank you so much for giving me this opportunity, Aparna, and thank you for making learn again good things from my seniors who I all hear. So thank you so much. Thanks a lot.
Thank you, ma'am.
Thank you,
Thank
Dr.
you, ma'am.
Prana.
Thank you, ma'am, and thank you for telling us about the government initiatives, and also we are interested in the point of care testing. So I'm sure with the guidance of Dr. Khurana sir and Dr. Bimal sir, we will be coming to you back for the point of care implementation, and let us see how we can take it forward as an SFM initiative also. So thank you, ma'am. And now moving forward, we'll talk about the management of preeclampsia. So she's a 23-year-old lady who's coming to us, she's a known case of intermedia. So most of the major women may not be able to conceive, but she's a thalassemia intermedia. But before we go on to the management, just talking about the preconceptional concerns, how to optimize the preconceptional period in this woman. What steps would you like to take? Dr. Vandana.
Yeah, Parna. So first thing is that, yes, there is a chance of infertility more because of hypogonadism. But if she wants to conceive, she will need some ovulation induction. But before that, we need to counsel her in detail about the risk to the mother as well as to the fetus that she has. So they are end organ damages which we want to see. So we would want to first see the cardiac dysfunction. So an echo is required, an ECG required. If the ejection fraction is less, then we need to caution her on that. Liver functions, yes, because there's more of iron overload, and so we need to look at liver functions. Also look at gallbladder for stones, as you've written here. They have been on transfusion, so we want to look for infections, HCV, HBsAg, and HIV also to look for whether she has any infection. In addition, all the endocrine disorders will be more, so they could be having gestational diabetes later on, or they could be diabetic now itself. Hypothyroid also possibility, bone osteoporosis. So we need to do her bone density, calcium. So there are a lot of things which need to be screened prior to her conceiving. So bone density, vitamin D. She might be on chelating agents, so we need to change it to desferroxamine. And that also first 3 months we can't give that. So we want to bring down her iron overload to normal levels and then ask her to conceive. And finally, folic acid. What we give normally is 400 microgram. Here we would want to give more. And so 5 milligram of folic acid needs to be started for this patient. So it will require a multidisciplinary approach. So you will need to have a hematologist, a good obstetrician, a high-risk obstetrician, a fetal medicine. You need to have your cardiac person on board. You need to have your ortho person on board, and you will need everybody in place, and more visits are required, more scans will be required because more chances of IUG are also. So she will need to understand all this before she gets into her pregnancy.
Yeah, so I think, yes, this is a high-risk pregnancy and needs to be monitored very carefully. So Dr. Chinmay, just in brief about what are the precautions and, care schedule, ultrasound scans to be done in this pregnancy?
Okay, so just we have already checked that the mother is affected, but the father is normal, right?
Yes.
We haven't screened the father.
Yeah, so in this particular pregnancy, we have the mother is the one who's affected. She's a thalassemia intermedia, and the baby is all right now because the father is normal. So just the antenatal care plan, because we do come across such pregnancies.
So here we are not concerned about prenatal diagnosis per se, but we are more concerned about the health of the mother. And like Dr. Vandana said, it will be a very good idea to have the multidisciplinary care team in place, where the hematologist is one of the most important people. And other than that, we need the cardiac specialist, because the long-term anemia and blood transfusions and iron overload will have some impact on the cardiac function of the mother. So that needs to be checked well in advance. Then the liver function of the mother also has to be checked, so that we are not looking at any condition where, she has a liver dysfunction because of the pre-existing iron overload and things like that. If all this is okay, we are now going to concentrate on the, fetal development inside. So like our routine scans, we do the viability scan, we do our nuchal translucency and the first trimester screening for aneuploidies, because she is going to be treated like a normal condition as such. And then we do the anomaly scan around the 18 to 20 weeks. Thereafter, this is not an indication for doing individual fetal echo or something, because the fetal heart is not supposed to be at risk particularly. But in any case, we'd like to keep a 4 to 5 weekly watch on fetal growth, because the mother herself will be under so much stress that there could be fetal growth restriction. So looking for fetal growth and Dopplers at a 4 to 5 weekly interval, and trying to take the pregnancy as much as closer to term would be the aim of antenatal care from our side. And of course, like you said, the hematologist will have to come in when it comes to the plan for transfusions and iron gelation.
Yes, so thank you, Dr. Chinmay. And now I'd like to ask Dr. Khanna about pregnancy, how does it present the challenges and how do you manage these transfusions and iron chelation in pregnancy?
So actually, speaking about pregnancy in thalassemia major is different from thalassemia intermediate. See, first I'll talk about thalassemia major case who gets pregnant. We are very clear that the hemoglobin should be maintained above 10 gram percent for the fetal growth, and there is no problem. Since majors have more of these raised ferritin level or the iron overload. So in these cases, we make sure that, like if the lady has been very well maintained, her ferritin is normal, and we can get that nowadays T2 star MRI done. And if her T2 star is more than 20, means she is not iron overloaded. In that case, we don't do anything during pregnancy because she is very well maintained and we'll watch her throughout. But if her T2 star is very low, say less than 10, or she has got severe heart iron overloading, then in that case, as Dr. Vandana said, that desferol can be given to them during third trimester of pregnancy. And other two, regarding desferol, I'll just say that there are reports which say that it can cause skeletal deformities but they are all equivocal. All those reports have been proved in animal studies. Till date, there is no human study showing skeletal deformities. That's why we allow them to use desferol. Other two chelators, deferiprone and desferrioxamine, we have very insufficient data to say that they can be used in pregnancy, so we don't use them. And now there is one situation where the mother's condition, heart condition is deteriorating or it is progressing. In that case, we can start desferol even in the second trimester, or some people have said that rarely somebody has used even in the first trimester, but we say the Thalassemia International Federation says that you can start in the second week of pregnancy, second trimester of pregnancy. I'm sorry about that. And one point I would like to make about this, that these thalassemia patients, when they go to the term during labor, they should be given a drip of 2 grams of desferol throughout the labor. Why? Because see, most of these thalassemia major patients have high iron load, and there is a capacity to which the transferrin can bind to iron. When this capacity is full, then free iron circulates in the blood, and that is called non-transferrin bound iron, and that is the form of iron which is highly toxic. So to cover this stress, to remove this NTBI, non-transferrin bound iron, during pregnancy, during the labor period, because labor is a very stressful situation and some of them may have even acidosis. So cardiac decompensation can take place during labor. So we cover this period with the desferrioxamine. Now, about intermedia, it's a very tricky situation, because if you give blood transfusion to thalassemia intermedia who is not been transfused earlier or infrequently transfused, they get allosensitization very fast. So we have to be very careful. If any situation arises, if the doctors decide, hematologist or thalassemia specialist or the obstetrician, then in that case, we give them the fully phenotype matched blood. We don't give them just RH and ABO compatible blood. And the situations are that, like if the mother, we consider everything, not only the hemoglobin, mother's condition, her cardiac status, and main is the growth of the fetus. Even the RCOG people say that if the lady is maintaining hemoglobin above 8 and fetal is growing well, no need to give her transfusion. And about chelation generally, Thal intermediates, they don't have that much iron overload, except if the overload is in the liver, because they don't have that much iron in the heart.
Right.
So I would not like to discuss that here.
Right. So thank you, sir. I think 2 points that you've said is in major, maintain the hemoglobin above 10.
10,
And of
yes.
course, you have to individualize the chelation. And if it is necessary, please give the chelation, because it is relatively safe in pregnancy if it is to be given. Yes.
Yes.
So thank you, sir. And just one more question, whether we should be giving thromboprophylaxis for all women with thalassemia major who are pregnant.
See, for thalassemia, no, not all women will require. As I said, yes, thalassemia with splenectomy, those who have undergone splenectomy or whose platelet count is high, either we give them low dose aspirin throughout the pregnancy. Many of them would be already on ecosprin, like those cases of splenectomy who have this thing, serum, platelet count high, we give them aspirin throughout. And then those who have got splenectomy and platelet count both high, then we give them, in addition to that, low molecular weight heparin also. The
Right.
dose is 0.4 ml subcutaneously daily, and it may be again required throughout the pregnancy. Then intermittently, if these patients get admitted, then also we should give them this thing, low molecular weight heparin.
Right, sir. Thank you, sir. So because this thromboprophylaxis is an important aspect of management of these women, so something to
See,
be...
this thromboprophylaxis is very important for in cases of Thal intermedia. In Thal majors, we suppress their ineffective erythropoiesis by giving them regular transfusion and by raising the hemoglobin above 10. But in Thal intermediates, you see, they have abnormal RBCs and platelets circulating in the blood. So that is more hypercoagulable state or thrombogenic state. In those cases, again, all splenectomized should be, again, similar situation, all splenectomized should be given low dose aspirin throughout the pregnancy. Or if there is any thromboembolic event before that, or there is history of recurrent abortion, then also we consider them for low molecular weight heparin.
Right, sir. Thank you, sir. So thank you for bringing out that difference. We'll just, I think we are just already 10:30. So I will just ask Dr. Chinmay to, raise a few points, and then we will conclude. What are the consideration of intrapartum care and the postpartum care in these women?
Yeah, so I think most importantly, intrapartum care would be to decide the mode and time of delivery first, which will be totally on obstetric decision conditions. And just the presence of this kind of hemoglobinopathy does not become automatically an indication for cesarean section. Pain relief and hydration in labor are very important, and that should be provided by regional anesthesia as far as possible, because epidural anesthesias are considered to be, analgesia is considered to be good for these patients. Whenever we do a cesarean section or a surgery, we would like to avoid a general anesthesia, not only because of the risk of hypoxia, but if you see the RCOG guideline, it says that prolonged, the effect of the hemoglobinopathy can affect the TM joint of these patients, and providing a general anesthesia and intubation and all these issues can be a problem there. So continuous electronic fetal monitoring for the fetal well-being, and active management of the third stage of labor, so that the woman doesn't get very exhausted and dehydrated in the process of delivery itself. To the high alert for thromboprophylaxis at all stages. Intrapartum, of course, we are taking care of hydration, but in the postpartum period, I think the most important thing would be to provide thromboprophylaxis, facilitate early ambulation and early recovery from delivery, and advices regarding further contraception, and in spacing the pregnancy so that she has a good recovery period.
Right. Thank you, ma'am. And so the recent advances on the non-invasive diagnosis has been covered by Dr. Kusha. So I think we'll skip this part, Dr. Vandana. And just a question, that is there any in utero therapy on the horizon?
There could be a change in the gene which is affected. So it is still in research. So I don't think it is going to come in next few years. But
Right.
NIPT would come in for thalassemia screening more, especially
So-
the paternal mutation that we could find out.
So
Yeah.
here I would like to inform that we have given a project to CSIR IGIB for gene editing. So it's a big project from DST side, and MOTA and DST are coordinating about this because it's important to inform everybody about this. And Dr. Tulika from Hematology Department of AIMS is the part of it. And Rishi and Dr. Tulika and Dr. Manoranjan Patra, three of them are part of it. And we have also taken some other institutes for this. So I think they have pretty done a good job, and we can also basically link all of you with them also to know exactly how, because this has been linked to entire country. And I'm basically coordinating and monitoring this impacts of these gene editing. So we this basically all the doctors can be involved easily into this. So it will be good if anybody wants to get involved into it. Just let me know for this. So sorry for interruption, but this
Oh,
was
no, thank you,
important.
ma'am. And I think it's important to, know about these things so that, we can get involved in, whatever form and at the earliest stages that is possible. So thank you very much for this input. And we do look forward that, some treatment is available around the corner. So just to conclude, we all know that, it's an important differential of microcytic hypochromic anemia, and high index of suspicions along with algorithmic approach is very, very prudent. And prenatal diagnosis, I think this is what this entire meeting is there for, that we have a facility for suspecting, for diagnosing, for managing before, so the entire aim is to have a prenatal diagnosis for situations where there is no affected baby also. So I think with that, I would like to thank all the esteemed panelists for their excellent inputs. And we do hope that this movement of thalassemia awareness really picks up pace. And as Dr. Khurana really mentioned in the very beginning, that whatever we are doing is not enough, and today is the day when we actually take up this mantle, and that we take it really forward. So thank you very much, and I'd like to hand it over to Dr. Khurana, sir.
Thank you. Thank you, Dr. Aparna, for bringing out those cases and making sure we get the right messages. And a very special thanks to our special invitees this evening, Dr. Vinita Srivastava and Dr. Virender Khanna, for bearing with us and giving us such brilliant insights to make sure that we don't have a lopsided view of the whole situation. Thank you indeed. And I promise Dr. Vinita Srivastava that we will put one of our team onto the job to get our SOPs in place so that we can have guidelines from now on. And let me hand that task over to our very kind General Secretary, Dr. K. Aparna Sharma, to take this forward without any delay. Thank you very much to all the other panelists as well for making us believe so clearly that we are on the right lines so far. Now, we have a very interesting task for us before we go on to the questions from the audience. And this is the inauguration of the Society of Fetal Medicine Bengal Chronicles. And I hand over the stage now to Dr. Kanchan Mukherjee and his team, and to Dr. Bimal Sani. And we go ahead with the inauguration of the newsletter, which we now call the Chronicles. And we do hope other regions will also follow. So over to Dr. Kanchan Mukherjee and Dr. Bimal Sani for the inauguration. And first, of course, we have a little inaugural video. So the back office to please put on our little inaugural video. Excellent. So as you know, this is truly an inauguration. We know we're going to move to the real world soon and it won't be virtual anymore. Okay, Kanchan, all yours, and Bimal, all yours. Kanchan, you have to unmute yourself. Yes.
Thank you, everyone. Thank you, everyone from the central team and Conferences International for bringing our dreams into reality. I don't have much to say at this time of the day. I can only say that we have taken up a daunting task. It's a long-term commitment, and thanks to my team, where I would thank especially Prasanna, our honorary secretary, for taking the mantle forward. And it has been a team effort, not just Prasanna, it has been the entire EC. And even though we have started it, I think it should be considered as SFM property. We are not in isolation. Everybody is involved here. So let us take it forward further. Thank you all.
Congratulations to the complete team and this whole the group which is put together, right from thinking about the idea of the newsletter and then planning out what all we would do in that, and then finally deciding. And it's been a rapid fire approach in a very, very short time. The whole thing was planned and you've started off and you've come up with your first newsletter. I really love the name, the SFM Bengal Chronicles. And so hearty congratulations to the Bengal team and to everyone in SFM, I would say. As you rightly pointed out, see, everything is the Society of Fetal Medicine. So whether it comes from Bengal or from any place is something which is an achievement of the Society of Fetal Medicine, and hence congratulations to everybody, every member of the SFM, that yes, this is the first newsletter we have. So, and I think this would go a long way motivating other chapters also where they come up. And this would be a good opportunity for people to come up with their informations. Then even for the members to get an idea about what is happening around. And in this particular, in the first episode, and in fact, that would be something which will be repeated in every newsletter, and that we had a competition for the best image. And in this, the first newsletter, the winner is someone whom I have nicknamed the Picasso of the SFM Bengal group, and that's Dr. Shankar Day. Hearty congratulations to Dr. Shankar. And of course, we will spread this newsletter around. Everybody would be able to see the image. And we expect, it's very nice. It has begun, but the team is very enthusiastic. They want to do a lot, but all will depend upon the contributions which come. So I think every member needs to contribute something towards the journal, maybe in the form of cases, maybe in the form of good images. And that only will, the quality of the newsletter will be persistently high. And I'm 100% sure with Dr. Kanchan and Prasanna and Dr. Ghosh to guide them, we expect a lot of good newsletters coming from SFM, and a lot of good SFM Bengal Chronicles coming our way. Hearty congratulations again, Dr. Kanchan, great job, and for your complete team. Dr. Khurana, sir, would you like to say something, sir?
Yes, I'm hoping that we see more chronicles coming out from the other regions as well. We have Dr. Chinmay Rath, who is the chief of our Telangana chapter. We have in the audience, I see Dr. K.V. Sri Devi, who is chief of our Andhra Pradesh chapter. And then I can see Dr. Manju Chilani from Chhattisgarh. I also see Dr. Hasmukh here. And so we want each one of you to get inspired to actually move this. I see Dr. Manohar from the south, and I really look forward to them to make sure that we get the chronicles initiated from each place, so that the little bit of talent that we seem to be missing out and need to encourage to come forward comes forward faster than it would otherwise. And so congratulations, Team Bengal, for actually doing this. And I look forward to many great issues. And thanks so much for this. But we now move on to the last section on the questions that remain unanswered. We have a few of them in the chat box. Some of them have been answered, so we won't take up those, but certainly the ones that remain unanswered. So over to Dr. Kanchan Mukherjee and Dr. Aparna Sharma for the questions.
Yeah. Do you want to take over, Aparna?
No, sir, please carry on.
Basically, the question that was there, which has not been answered yet, is, of course, came from Prasanna, is if the mother is thalassemia intermediate, then how do we manage the pregnancy? The only thing is, if the father is not a carrier, then we do not need to do any prenatal. And in terms of her antenatal care, I think it has already been discussed. The another unanswered question is the situation where first child is thalassemia major, and in the subsequent pregnancy, when you try and investigate that, you cannot find a mutation in the mother. So how do you approach this situation?
Can we ask Dr. Ratna Puri, ma'am?
I thought so.
Yeah. Okay. So so most of the times, beta thalassemia is inherited from both partners. Okay. But this is science and not mathematics. I have seen only one case where it was a new mutations. So in some autosomal recessive disorders, it is not inherited from one parent, but during the process of gametogenesis, the change occurs. So that is referred to as a de novo or a new mutation. And as a result of that, the child has both copies of the HBB gene with the mutation and will manifest. So, but of course, before saying this, because this is a very, very rare event, you will go into the details, make sure that there is no sample mix-up, go back, check the mother, check the CBC, check the HPLC, hemoglobin A2, take details of the family history. I think we start from basics and then think of the rare things.
Can I say something? Ma'am, can I ask, could it be possible because of gonadal mosaicism as well?
So, well, yes, but we don't have gonadal mosaicism really for autosomal recessive disorders. That is a predominant feature of dominant disorders. But you could never prove that. You could never prove that, if you know what I mean. So in this case, if the second child is also affected with the same mutation that was present in the first child, then yes, indirectly you prove gonadal mosaicism. But if the second child is not affected, either because it was a new mutation and the same hit will not happen again, or by chance the child is not affected, you could not prove gonadal mosaicism.
Next question, perhaps Aparna, you might take over, is a role of aspirin in prevention of preeclampsia as a routine.
So I think this has been covered in the form of thromboprophylaxis also. I think aspirin should be given if the patient is, thalassemia, intermediate, thalassemia major. So I think those things, they have to be given. And of course, the role of ecosprin in preeclampsia prevention, we should really think about, the preeclampsia risk scoring and, go through the routine of it. But in the cases of thalassemia, yes, I mean, this is something that is an indication where we should be giving ecosprin 150 milligram, just to reinforce once again. Again, sir, I think there is repeatedly one question on thalassemia minor. And I'd like to ask Dr. Khanna that thalassemia minor at 30 weeks with 8.5 gram hemoglobin.
Thalassemia minor.
Yes.
If the fetal growth is okay and she doesn't have any other problem, then there's no need. But if it goes below 8, that is the cutoff that we take.
Right, sir.
Then we should give them transfusion. And remember, again, if any person gets repeated transfusion late, then there is a risk also.
Right. And
so, but in that case, we should give if it drops further.
Yes, sir. Thank you, sir. So sir wants to say that, 8 gram is the cutoff. Below that, give transfusion. Above that, just monitor the patient. I would also like to add here that most of our thalassaemic women are also iron deficient. So we also need to look into, the iron
Yes.
studies, serum ferritin, and, see what is the basic cause. If the ferritin looks good, more than 100, don't give iron. If it is low, ferritin is very low, and then, combined thalassemia and anemia due to iron deficiency, we have to manage according to that. So we should be involving our hematologist, but yes, we should keep our eyes open to iron deficiency also.
This is not an iron loading condition. Thalassemia minors can develop iron deficiency, and in fact, we recommend that all pregnant females with thalassemia minors should be given iron as you give to any other pregnant lady.
Yes, sir. Thank you, sir. Thank you. I think that is very important because thalassemia, we miss out on iron deficiency.
Yeah,
because we are not
the moment thalassemia word comes, I have seen people giving Desferol also to bring, because it's a thalassemia minor.
Yes.
So thalassemia नाम ही इतना डरावना हो जाता है उनके लिए कि क्या करें.
Iron नहीं देते. So I think, yes, sir, I think most of the questions are answered. One is timing of delivery, and Dr. Chinmay said that, thalassemia doesn't guide the timing of delivery. It is the obstetric condition that guides the timing of delivery. So there is no confusion on that part. And just one more question, last question that I would say, that there was this thalassemia, E beta thalassemia, not transfusion dependent. How is it possible? E beta thalassemia.
See, E beta thalassemia can present as transfusion dependent and NTDT also, non-transfusion dependent. I have a set where two brothers have same mutation. One is coming to me for the last almost 30 years for regular transfusion. The elder one has got the same E beta thalassemia. He is not getting any transfusion. He is maintaining reasonably good hemoglobin. He's got married also, he got children, no problem at all. So thalassemia, about E beta thalassemia, we don't know much in detail why they behave like this. There are some unknown factors which we don't know today, but some of them would require regular transfusion. Some may behave like NTDT, non-transfusion dependent thalassemia.
Right.
In the same family, I'm telling you, it has happened with.
Right. Thank you, sir. So, Dr. Kanchan, I think we've covered most of the questions.
I think so, yeah. They have been answered individually there. I mean, in the public forum, in the group as a group. Yeah.
Right, sir. So, I think, sir, Dr. Khurana, sir.
Thank you. It's really been quite an evening. There is just so much that we have learned from each other, and we've had so much insight into this with excellent inputs from our special invitees. Thank you, each one of you, for being here this evening. My thanks to the entire Bengal chapter for putting this together, for all the inputs on a hands-on management of individual scenarios. And of course, my thanks to Conferences International for always being there for us, for Vishal Mittal for always coordinating everything, and our trade partners, LifeCell and Redcliffe, for supporting us in these exercises. Thank you very much, and I look forward to more such programs that we can actually bring thalassemia to where it truly belongs. I really hope that in my lifetime, I'm able to catch up and say that, yes, where's Sardinia, where's Cyprus, here comes India. And then that would really make me happy.
No,
Thank you indeed. All the best and good night.
This is one session we would like to get it very fast onto the YouTube for all those who, because of a Sunday evening, have missed today's program, because since the main purpose is awareness, we will see to it that it comes on YouTube as soon as possible, so that all those who have missed can take advantage of this wonderful teaching. And, every one of them have really come up with, the kind of information on thalassemia that has come up in this last 2 hours is something nobody should miss. So we'll have it on YouTube very soon for everyone.
Excellent. Thanks very, very much.
Good night.
Good night.
Thank you.
Thank you, sir. Thank you.